usually when we suspect stroke, we believe that time is the most important thing. That means how fast we act is the most important thing. And the general consensus is that we should do the CT scan. We generally do an uncontrast CT scan of the brain as soon as we suspect that there is a stroke. And the CT scan should be done within the first 25 minutes of the patient landing in a hospital. And if we are going to thrombolize, if the patient meets criteria for thrombolysis, that should be done within the first 1 hour. So that is the kind of general timeline that we try to meet when patients arrive at our doorstep with a suspected ischemic stroke. So when we suspect stroke based on our clinical judgment, I would say the two most important investigations we need to do are the capillary blood sugar, which can be done at the bedside of the patient, because hypoglycemia can mimic a lot of neurological symptoms. Based on that, we would do a capillary blood sugar. It doesn't take more than even a second to do that. So you do a capillary blood sugar, make sure the patient is not hypoglycemic, because hypoglycemia can mimic a stroke. And then the most important investigation is to get an uncontrast CT brain done. So acute ischemic stroke, even in somebody known to you, the best place to go would be a kind of a bigger hospital and not the closest hospital. Because if you look at the timelines that I have given you, if the patient lands in a hospital and within 25 minutes we need to do a CT, this is one medical condition where we tell them to go to the closest, biggest hospital where thrombolysis facilities are available. So what would be best is when you all are posted to your intern station, which you all haven't got yet, to find out what are the closest hospitals which have thrombolysis available and which hospital facilities to do an uncontrast CT brain. So while you arrange this non-contrast CT brain, generally that the stroke team will be available in the hospital. The stroke team will consist of the on-call radiology consultant and the trainee, the neurology consultant and a trainee, and the medical registrar generally. So you should alert the stroke team that the patient has arrived, and then you would immediately get the non-contrast CT brain done. And this non-contrast CT brain has to triumph any other non-contrast CT request that you have, because time is brain. And you can send all the other investigations, but you don't wait for the result of the other investigations. The only two investigations you will wait for the results are your capillary blood sugar and your non-contrast CT brain. So then, once you decide that the patient needs thrombolysis, provided the non-contrast CT is normal, generally we would thrombolize up until 4.5 hours. So this decision is generally not taken by an intern, or we are trying to train you all to be good interns in a medical ward. But it is good for you to have this knowledge, because you need to know that you can thrombolize up to 4.5 hours, provided there are no contraindications. But beyond 4.5 hours also, now there is evidence and the guidelines also support the use of thrombolysis, provided certain criteria are met. So these criteria, a person who's senior than you will make this decision, but it's good to know that you must not say it's not possible to the patient. Most of the time, a lot of problems in medical wards happen because we try to give information and advice which we are not fully competent about. So if you don't know the exact information, it's always better to alert your seniors and they will make this decision. So within 4.5 hours, no contraindications, you can thrombolize. Beyond 4.5 hours, up until 9 hours, there is provision for thrombolysis, provided we do additional imaging. So this additional imaging of CT and MRI perfusion might not be available in all the hospitals that you all are posted to. So this decision will be taken by a senior. But make sure that you say nothing is possible for the patient when the patient lands after 4.5 hours. So then, talking a little bit about thrombolysis, we can use either RTPA or tenecteplase. The earlier we give it, the better. RTPA was a traditional drug that we used all this time. So it's given as a bolus initially and then as an infusion. And it has a very short half-life. So, but now there is increasing evidence to say that tenecteplase can be used as equally effective as RTPA. And generally, RTPA, one of the two common problems that we have, the commonest problem you would have would be an ICH. When we thrombolize, they can develop a hemorrhage. The other problem would be angioedema of the oropharynx, which is of course not very common. So if it does occur, we can of course treat it. So that is not a contraindication not to give thrombolysis. So we all need to know the contraindication for alteplase, because this has to be verified very clearly with the patient. And this has to be done by you all, because you all take the history and examine the patient. So these contraindications have to be clearly documented in the bedhead ticket. And as I told you just now, tenecteplase can be equally used as much as RTPA nowadays. There is a new guideline and a guidance statement in 2023 which promotes the use of tenecteplase, because tenecteplase, the administration is easier, it is very much of a lower cost, and they say there is comparable safety and efficacy data. So because of that, you can either use alteplase or you can either use tenecteplase. So this slide, I think, is the most important slide as interns for you all. So when you give thrombolysis, when the stroke team decides to give thrombolysis, you as interns must know that the next 24 hours is very crucial. You cannot isolate that patient. That patient needs very close monitoring. So as interns, you have to have very close monitoring. The nurses will help you with the monitoring of the patient, but you have to be very alert to any problems that can develop. Because a patient's stroke, despite thrombolysis, can expand. So new neurological deficits might come through. After RTPA, you can have bleeding in the brain. There can be any other bleed like GI bleeds. So there are lots of complications that can happen. So this monitoring, this strict monitoring, as you can see, in the first 2 hours is every 15 minutes. Next 6 hours every 30 minutes. Next 16 hours is every 1 hour. So this monitoring has to be absolutely done to perfection, because otherwise it is going to be a problem. So this is very, very important. And at the end of this 24 hours, we would generally do a CT scan. And if there is no hemorrhage, we would start the patient on antibiotics. So this monitoring, there is a chart printer in hospitals. All hospitals will have this chart. If there is no chart printer, you can even write it in a VHD and do the monitoring chart. So within the first 24 hours, as you understand, once you thrombolize, the patient is at very high risk of bleeding. So you try not to meddle with the patient too much. I mean, if you want to absolutely need an NG, absolutely need a catheter, you can go ahead and place them. So, but you have to make sure that you don't meddle with the patient unnecessarily, because the bleeding risk is very high. And one of the most important thing is, before you give thrombolysis, you have to make sure that the patient's blood pressure is less than 185 by 110. Unless it is at that level, you cannot give thrombolysis, because the patient is going to bleed. The bleeding risk is going to be very high. So before starting, it has to be 185 by 110. And once you start, also over the next 24 hours, make sure that it be less than 180 by 105. So over the next 24 hours also, the bleeding risk is very high. So you have to make sure the blood pressure is less than that. Apart from thrombolysis that I spoke to you about, there is also something called thrombectomy, which is available at the National Hospital as well as certain private sector hospitals. So this possibility exists in Sri Lanka, and the guidelines also recommend it for certain category of stroke patients. But the problem in talking about this is, at many of the hospitals in and around the country, we are not able to do this CT angiogram or MRI angiogram in an emergency. And because of that, this possibility and the usage of thrombectomy is much less than what we want it to be. So this is also another decision that a senior will make and not an intern will make. But again, the most important, why I put it down here for you all is, now, if the patient has a contraindication for thrombolysis, I showed you the contraindication for thrombolysis earlier. So if somebody has a contraindication for thrombolysis, don't say that, oh, you should have come 4.5 hours early and you could have done this. Now nothing is possible. Don't give information of that sort out to patient, because if the patient can be transferred to a tertiary care hospital where thrombectomy is possible, things are still possible. So don't give information of that sort unless you consult a senior, because these things are available. And unlike for thrombolysis, for thrombectomy, the time limits are a bit beyond 4.5 hours. Even up to 24 hours, it's possible, provided certain criteria are met. So I don't think you all at your level need to know the criteria, but what you must ensure is you don't tell the patient nothing is possible when they arrive after that due time limit for thrombolysis. So this is available in Sri Lanka. It's available in the government sector as well as the national hospital. So don't say nothing is possible. That's why I put this slide. So as you can see, it's a bit of a complicated slide, because there are lots of information which we can't make with an uncontrast CT brain alone. From the non-contrast CT brain, we can calculate the aspect score, but beyond that, the perfusion scans are needed, and that is not available in most hospitals around the island. And as you can see, even up to 24 hours, thrombectomy can be done in certain situations. So we must keep those options open for the patient. So apart from that, I believe that you would have heard about the word MRI stroke protocol, which includes your DWI, your FLAIR, and your angiogram, etc. So this is available at tertiary care hospitals and also in the private sector. So this is to identify when we are going to do patients, when we are going to subject patients for mechanical thrombectomy. And it can also identify a lot more information than one uncontrast CT brain. So, but of course, this MRI stroke protocol is not available in all hospitals around the island. So, but if the patient is at tertiary care hospital and you're doing an internship at National Hospital also, then this is available, and then these things can be done. But from an intern point of view, in a general perspective, if there's a stroke patient, you need to do an uncontracted CT brain to exclude hemorrhage. Thereafter, if thrombolysis criteria is met, you thrombolize the patient if there are no contraindications. If thrombolysis is not possible, you see whether the patient can undergo thrombectomy, which senior will make that decision. And up until such time, don't say that nothing is possible to the patient. And this, I think, is very important to you all with the blood pressure control. I told you earlier, if you are going to thrombolize a patient, you need to get the blood pressure under 185 by 110. And over the next 24 hours, you need to keep the blood pressure less than 180 by 105, because otherwise the bleeding risk is going to be high. But if you are not going to thrombolize, we generally try not to reduce the blood pressure unless the blood pressure is very, very high. That is more than 220 by 120. Or there is another reason to bring the blood pressure down, such as a hypertensive emergency. So this is very important. So we would generally give labetalol, which is available in the state sector hospital as intravenous antihypertensive. We would give it and get the blood pressure down to make us to enable us to give the thrombolysis, and also if the blood pressure is very high. And apart from all of these blood pressure control, the thrombolysis, thrombectomy, we also have to make sure that the general supportive management of the patient is optimal. So blood sugar control has to be kept less than 180 milligrams per deciliter. In most acute conditions in the medical ward, we will try to maintain the blood pressure around 140 to 180. Not too low, not too high. And then you have to make sure the saturation is all right, more than 95. And if the patient is unable to be, patient cannot be mobilized, you have to make sure DVT prophylaxis is given for the patient. And beyond the 24 hours that I spoke to you about with regard to monitoring, after the 24 hours, it will be ideal if the hospital has a stroke unit, because of course there's going to be a multidisciplinary team there, and the management is going to be better than the acute medical ward, because in the acute medical ward, you have lots of other patients also that you need to take care of. So if there is a stroke unit in the ward, in the hospital, you can transfer the patient there. But if not, you need to give the best possible care within the setting that you have. So you need to monitor the vitals. You need to make sure that you monitor for complications of stroke. And you have to understand that if the thrombolysis has not worked, if thrombectomy was not possible, if the patient now has a neurological deficit, you need to address this deficit the patient has. If the patient can't see, you have to make sure that they have somebody with them who can help them. If the patient can't talk, and if the patient can write, if the limb weakness is not there, you need to give the patient a notepad and a pen to express what they want to say. Otherwise, they're not going to be able to communicate with you. You can ask questions, but they of course not be able to answer the questions. And make sure that the bladder care is maintained. And as soon as possible, medically fit, you can start on physiotherapy and occupational therapy. And of course, you can imagine if you are one day walking and you suddenly get a stroke, and then thereafter you can't talk, your one side of the body is paralyzed, you're invariably going to be depressed. So to assess the patient's mood and do the necessary referrals if there is depression, if there are mood changes. So all this management happens in the medical ward, but this will be catered according to the deficit that the patient has. So beyond the acute medical care, you need to sort out these problems also in a stroke patient. So that's about acute ischemic stroke. I would shortly mention a little bit about in brief about the acute hemorrhagic stroke. So in acute hemorrhagic stroke, generally we would have traumatic ICH and non-traumatic ICHs. So the management is a little bit less complicated, but these patients are generally more medically unstable than your acute stroke patients. So because when they have ICH, unless it's a deep small ICH, they're generally much more ill. And you have to be able to make sure that the patient's airway is maintained. So make sure the patient has a patent airway. And apart from that, blood pressure control in this situation is going to be much crucial than your ischemic stroke. The reason being, in ischemic stroke, I told you that we need to maintain the blood pressure less than 185 by 110 if the patient is going to undergo thrombolysis. Otherwise, our targets are above 220, 120, and then only try to reduce it. But in acute hemorrhagic stroke, we need to get it less than 140 as soon as it's possible, because unless we control the blood pressure, the bleeding is going to expand. So this is in contrast to your acute ischemic stroke. So if you have a hemorrhagic stroke patient, you need to have very strict blood pressure control. Apart from that, just like in acute ischemic stroke, the general management of the patient is also important. Fever has to be managed, sugar has to be managed. If the patient has swallowing difficulties, you need to deal with them. And you also need to address the coagulation. As you can understand, if there is a bleed in the brain, if there is a coagulopathy, you need to correct the coagulopathy. But prophylactically, giving vitamin K, giving FFP, giving cryo is not advocated. A lot of units practice that. So prophylactically, you don't give any of these things, cryo, FFP, vitamin K. If the patient has been on anticoagulant, either warfarin or the DOACs, or if the patient has been on enoxaparin or heparins for another indication, then you can reverse it. But prophylactically giving these agents is not advocated. Apart from that, try to maintain the sugar, hydrate the patient, make sure the patient can eat, get NG in if it is necessary, do all that supportive care. And another important element is this seizure control. Again, with ICHs, you can have fits. If there are fits, you treat the fit. But just like correcting coagulopathy, this is also not indicated prophylactically. That means anti-epileptic drugs are not given prophylactically if the patient does not have fits. So that's another important thing you need to remember. You give antiplatelets, you give anti-epileptic drugs, and you correct the coagulation only if those problems arise. None of these things are done prophylactically. And apart from that, when it comes to ICH, there is a place for surgery, and we need to know who are the candidates who need to be referred for surgery. So generally, this decision will be taken in collaboration with a neurosurgeon. So if there is no neurosurgery available in your hospital, you need to talk to the closest neurosurgical unit and decide on this management. We would generally send them the CT scan, alert them about the patient's GCS status, and we will make that decision. But the general guidelines are, if it's a very superficial ICH, they can do surgery. And if the patient's GCS is intermediate, somewhere around 9 to 12, then they might consider. And the most important indication is a cerebellar or posterior fossa hemorrhage, because the possibility of getting obstructive hydrocephalus is very high in posterior fossa hemorrhages. Because of that, generally they would intervene. So this, you don't have to make this decision. What you need to do as an intern is alert your seniors. They will liaise with the neurosurgical unit and they will make the decision together whether the patient will benefit from neurosurgery for this hemorrhage. So that's about ICHs. So in summary, I would like to say that you need to clinically suspect a stroke. If you suspect a stroke, you need to act on it immediately because time is very, very important. And a stroke, you cannot manage it on your own just because you're in a medical ward, a medical intern, you cannot manage it on your own. You need the radiologist to get a CT pass. You need a neurologist to help you with the thrombolysis. But of course, there are certain hospitals around the country where the physicians thrombolize patients because neurology services are not available around the country. So physician/neurologist both can make that decision. And communication with the patient and family is the most crucial thing. I would say this is the most crucial thing as interns for you all, because unless you tell the patient what you're doing or what you're planning on doing, they're going to get all kinds of wrong information from other levels of staff, and that is going to be detrimental to the care that you're providing. Because even if you do everything ultimately, the patient is going to get a wrong impression. I can give you a recent example that we had in one of our casualty wards. About a month ago, the medical casualty ward was carried out in a different ward away from our routine ward at Kalabovida. And there was a patient who I met during my morning ward round. He was 40 years. He was a journalist, educated patient. He was 40 years. And he told me when I went to his bedside while doing the ward round with the medical student that the day before night he had come with a stroke. He had come 5 hours after the stroke. At that point, everything had been done. In the sense, the patient had been seen by the intern on time, the registrar on time, and alerted the neurology team because we do have neurology service at Kalabovida. They had made the decision not to thrombolize because he had a minor stroke. He did not meet the criteria for thrombolysis. Thereafter, in the night around 2 a.m., the patient has complained of worsening symptoms, and he has said that his left arm was feeling numb and weak. And the house officer who was there at that time has said, ඔයා ආවෙත් ඔය ප්‍රශ්නේ හින්දානේ That had been the response. So what he had in reality was his initial stroke was mild, and with time, the stroke had progressed. So the house officer at that point had not alerted it to the registrar, neither to any other senior level, and the patient had a lot of complaints in the morning, which I believe is totally understandable because the patient was only 40 years. He was a journalist. His right hand was the problem, and he could not now work. Had we attended to the patient that night, at that time when he complained, we would have considered thrombolysis because though he came with a minor stroke, the stroke had been an evolution and he developed symptoms later on in the night. So what you need to realize is as an intern in a medical ward, we don't expect you to take all the decisions. There are seniors, there is help available. You can always talk to the consultant if you think the immediate senior level is not attending to your problem. And if you think that something needs to be done, you need to alert them. Unless you tell them the problem, they can't deal with it because you're the first contact for the patient. And especially in stroke, unless you tell them what we plan on doing and why we couldn't do that and why we did that, the patient is going to get a lot of wrong information. So at least even for their next family members, say suppose they came beyond the time limit that we can do anything, if you tell them what we could have done, then at least for the future encounters with hospital, they will come on time and then better outcomes can be expected. So I think communication with the patient and the family about what we are doing in the ward is the most important thing. We do everything possible in the medical ward, but the problem where we lack is in the communication. So if you tell the patient what we are doing, that would be the most important thing. So that night, had the house officer alerted the registrar or the senior registrar about the problem, we could have dealt with the problem in a very different way. So the take-home message is: if you suspect a stroke, you need to alert the stroke team. You need to alert your seniors. Time is the most important thing. Getting the non-contra CT brain done, and thereafter attend to the problem based on what we find. And then communication is the most important thing. Your stroke patient might be just a stroke patient for you in your acute medical ward. You know that you can't do anything, so you might want to send your ICH patient home the next day. But for that patient, he was walking, talking, and he suddenly has a huge neurological deficit. So we need to tell them about the NG, about the catheter, about the blood pressure, when to come back to clinic. So unless you do all of that, the patient is not going to be happy with the care that we give. So whatever your hard efforts and your work and all the time that you spend in the ward is going to be a waste unless you tell the patient what needs to be done. Okay. If there are any questions, just send it in the chat box because the time is up.
We have about 6 minutes, madam, so we can take up any questions if anyone is having.
I think the best thing for you all to do is as soon as you go to the hospital for your internship, now you haven't got your station safe, the best thing for you to do is look around, see what the hospitals are and around you, and first find out whether your hospital is capable of thrombolysis. If not, find out what is the closest hospital where the non-contra CT brain is, where thrombolysis facilities are available. There are about, I think, 16 to 17 hospitals around the island where thrombolysis is possible. So stroke is one medical condition where we say not to go to the closest hospital, but to go to the closest bigger hospital. Because once the patient lands in one healthcare institution, to do the transfer to the next healthcare institution, it's not very easy, and you can't do this process in 1 hour. Once you start working, you will realize when the patient lands at your doorstep, to get the patient out to the next appropriate level of hospital definitely takes more than 1 hour with all the documentation, etc. So the minute you go to the hospital, do your medical internship, find out where the closest thrombolysis facilities and the NCCT brain is available. So there's a question about when to review a patient after discharge. So it depends on what the patient has. Generally, we would review them depending on the deficit that they has. And you know that I didn't talk about those other problems. The patient has atrial fibrillation, we need to start on anticoagulation and things. So depending on what the patient has, because generally we would start anticoagulation after about 2 weeks. That's also the clinical decision based on a lot of factors. So when we review the patient, will be based on what the patient has. If it's purely a stroke, a minor stroke or a TIA, and we give dual antiplatelets for 21 days or something like that, then we can see in about 3 weeks. But if there are other clinical decisions that have to be made, like anticoagulation to start and things like that, you might review it earlier. So we might review it about 2 weeks after discharge. What you need to understand is not to discharge the patient. However heavy the ward is, don't discharge the patient in 24 hours unless you think everything has been done in the optimal way. Because I mean, for us, ICH is like a common occurrence. You might get, I mean, Kalgoorlie is every third day casualty, you would get ICH, like every casualty, like you get 1 or 2 patients when you combine both wards. So though it's such a common occurrence for us, from the patient's perspective, it's like a major problem. They need to find out the care, they need to get a water or air mattress if the patient is bedridden now. They need to learn, the bystander needs to learn how to give the NG feeds. Younger people the children are working, so the NG feeding has to be taught to somebody else. So there are lots of problems that need to be sorted out. So as soon as you think, okay, medically this is all we can do, don't send the patient unless those additional things are sorted. Even in ischemic stroke, it's the same. As soon as you do the ECG, rule out AF and do echo and rule out all these things and you start on antiplatelets, etc., don't push the patient out of the ward. You have to tell them what needs to be done, tell them about the risk factors for ischemic stroke, do their fasting blood sugar, do their HbA1c, do their lipid profiles, sort them out, tell them about the blood pressure. And another important thing is, you know that in Sri Lanka, we have alternative healthcare systems existing with our Western medicine. So you have Ayurvedic practice also. Whether you tell it or not, about 70% of our patients will seek Ayurvedic practice at some point of their life. So these stroke patients especially are more prone to go for these services because they have a lot of physiotherapy part of it involved in Ayurvedic system. They do a lot of oil application and massages and things. So what you can say is, without saying not to do it, you can say, if they ask you about it, you can say to do any kind of application from outside, physiotherapy, all that is fine, because that's what Western medicine will do as well. But as for the oral pills, to take what the hospital has given you. That way they understand that you are also you're understanding person and you agree that our medicines for future prevention of stroke is necessary, but the external applications, massages and things like that are fine. Because they will invariably go whether you say yes or no. But so if you tell them that, at least they will be compliant with the medication that you give. Your atorvastatin, your blood pressure drug, your antiplatelets, they will be compliant with that. Okay. Roshan Prof. Chandani has joined.
Yes, madam. I would like to add there will be a new national stroke guidelines will be published very soon. About another 1 month's time. It's in the printing, so we'll be announcing once it's been published. So add into your lecture, madam.
Thank you.
Right. Thank you very much, madam, for that detailed lecture. So next up is Essentials in Prescribing by Professor Chandani Manikatunga. Madam is logged in, so over to you, madam.
Good morning. Thank you. Can you all hear me?
Yes, madam.
Tushara, yes. It was a pleasure to listen to you. That was very good. So I'm going to share my screen now. Hope you all can see that.
Okay. Yes, can see and can hear.
Okay, thank you. So I've been asked to talk to you about good prescribing. I've been doing it practically for the last 28 years of my life. And I still see bad prescribing, and I still give this lecture hoping that somebody will pick up something useful and we will end up with good prescribing, which is essentially getting the best of medicines. So before I proceed, let me thank the Sri Lanka College of Internal Medicine for inviting me yet again. I guess we all live in hope that people will go towards good prescribing so that we can get the best out of available medicines, which is now becoming even more crucial because the available medicines that we have is getting limited by the day. So I'm going to take you through how we can get the best from medicines and also talk to you about avoiding medication errors, because that's part of this particular prescribing process. So if you look at prescribing, the Oxford Dictionary defines it as advice and authorization the use of medicines or treatment for someone, especially in writing. So it is basically giving advice in one way or the other, and also authorizing the use of medicines for a patient. Now, this authorization business is important for us because in Sri Lanka, according to the rules and regulations, only a medical officer with an MBBS or a dental officer with a BDS can prescribe medicines, especially those that are in Schedule 2A, 2B, and 3, and also those narcotics which are on a separate category. The only medicines that can be given without a prescription are in Schedule 1. Those are the ones that are available in supermarket shelves and shops and so on, the petty kades, around the country, like paracetamol, various balms and things which you can use. Everything else in Sri Lanka needs a prescription. And that prescribing is the domain of, as I said, MBBS or BDS graduates. So when you look at prescribing appropriately, it also involves spending less. That is from the government's perspective or the insurance company's perspective or from the patient's perspective, depending on who is spending for that medicine. It is also balance between prescribing what you want to know and the pressures that you're going to get from the industry who keep saying, prescribe my drug over the others. And it is important that as prescribers, we need to know what we are going to prescribe, irrespective of what the prescribers would, the industry would say, or the government would say, because ultimately what you want is to make sure that the person in front of you or your patient gets the right medicine for that particular person. It doesn't matter, the other things are all peripheral and they should never really take a precedent over what the patient needs and the patient's well-being. So the rest of my talk is going to be based on these 10 principles of good prescribing, which has been released by the British Pharmacological Society, and we have links with them now. So I thought it's appropriate to get that because that essentially covers up all the important things. So the first principle is that you need to be clear about the reason for prescribing. Why are you actually giving medicines? And that's the important question that you have to answer. And for that, you need to establish an accurate diagnosis as far as possible. As you know, when you get a patient at the beginning, you will really not know what exactly is wrong, but you will have a provisional diagnosis based on your history, your examination, whatever the investigations that are available to you at that time. So you can come to a diagnosis as accurately as possible. And that is where you start. Then you also need to be clear about how the patient is likely to benefit from the prescribed medicines. Now you have the diagnosis and then you know what the patient, what has to be given for that particular condition. That is what you've been taught up until now. But now you are going to decide out of all that, what medicines would my patient benefit from? Although this is what the guidelines say, will it be okay if I give this medicine to my patient or should I give something different? The next important thing about being clear about the reasons for prescribing comes when we have to do repeat prescribing. And that is probably what you will be doing most of the time in the medical clinics, because you will be seeing patients who come for follow-up management. And the tendency is to say repeat all. But do they really need all these medicines? Have the reasons for which we have started these medicines, are they still valid? Or do we need to continue these medicines? Do we need to change anything? That's very important. And this is becoming even more important because now increasingly in the clinics, only the book comes to the doctor and the doctor doesn't see the patient. And that is detrimental because the patients will not, whatever the problems they have, will not be conveyed to the medical officer appropriately. But it's extremely important, irrespective of whether you're prescribing in the wards or in the clinics or any other place, to be clear about why you are prescribing a particular medicine. And if you are not clear about the reason for prescribing, the best is not to give that medicine to that patient. The second important principle is to consider the patient's medication history before prescribing. And this is one that is becoming increasingly neglected because we don't take very good histories from our patients. So what medicines are they taking? What have they been taking until the time they came to the hospital? So it's important to know what they have been taking because sometimes you might, miss something which has to be continued even while they are in the hospitals. So taking a good drug history is very important. And that should include not only the prescription drugs, but the non-prescription drugs. And in Sri Lanka, although the rules say you can't give anything outside a prescription. All of us know that you can walk into a pharmacy and sometimes get the medicines that you want, although they may be prescription. So are they on non-prescription medicines? Are they on medicines that the family members have been given for various things and they think they have the same condition? They have taken those medicines. That is very common. And of course, the other over-the-counter medicines that they might take, those are important as well, because sometimes they can have interactions with the medicines that you want to prescribe. Then, of course, very important, whether there is a history of adverse drug reactions and allergies in the past, because the medicine that you might prescribe, might want to prescribe, might cause these problems if you are not careful. It's extremely important to ask whether there is a history of allergy, any allergy. Remember, as you know from your pharmacology, a person who's prone to develop allergic reactions for food and other substances are also more likely than others to develop allergies to medicines. So if it's a medicine that you know will cause an allergy, now that's the type of patient you need to be careful with it. If the patient has history of ADRs previously for similar medicines, then again, they are more likely to develop an ADR with these medicines. The third important principle is to consider other factors that might alter the benefits and risks of treatment. And these are the physiological changes that occur with age. And increasingly, we see a lot of older people in our practices, and they actually cruise along with limited reserves. And if you have an infection or any other acute event, they might suddenly be, die up while being cruising along with just marginally manageable renal function. This particular insult might push them to overt renal impairment, and that can have a problem with their medicines. So physiological changes with age, extremes of age, particularly children as well as adults, and in pregnancy are important things for you to consider. Then, of course, impaired kidney, liver, or cardiac function. If there is any record of previous impairment on these organs, it is important that you are aware of it and make the relevant changes to the medicines that you want to prescribe, either in the dose, the amount of drug that you're giving, or the dosing frequency, so that the patient will not have an adverse outcome, but will still get the benefit that you want to give this patient. Then, I think Tushar mentioned it earlier, people are different and you need to consider the patient's ideas, concerns, and expectations. It might not be exactly what you want. That's okay. It's a patient's individual right to decide what he or she wants. And it is important, therefore, to form a partnership with these patients when selecting treatment. And it is also important to make sure that they understand and agree with the reasons for taking medicines. And this is something we see over and over again when patients are on long-term medicines. They tend to forget why they are taking. Sometimes there are no symptoms or signs at all of the disease that they are being given medicines for, and they don't understand why they need to take these medicines. And the moment they don't understand and they don't realize why they have to be on medicines, they tend to stop. And that is when the problems start. And also, even though you might want to control the blood sugar perfectly, the patient might not really want to do that sometimes, although they know the repercussions of not doing so. They might have issues about taking medicines for long periods, and so on. Like, for example, sometimes people ask when you tell them to take inhalers, will I get addicted to it? The word is actually abbahivenada. That's a common term that they use. But, that's a concern that they have. And unless you address it, they're not going to take their medicines. And their expectations, sometimes they might expect you to cure the illness that they have. And you know that most of the diseases that we see and we manage, cure is not what we look at. We are looking at controlling the condition so that complications don't take place. So it's important for us to understand what the patients really want and then manage our medicines accordingly. Of course, selecting effective, safe, and cost-effective medicines tailored to the patient goes without saying. And today in our country, using the most cost-effective, safe, and effective medicine is becoming increasingly difficult because we have very little medicines available to us now. So it's very important that you are aware that some medicines might be more expensive than others. And you might be able to actually get the same benefit with a lot cheaper medicine that is available. In the state sector, asking patients to buy medicines from outside is a sure recipe for them to not take it because of the cost. So it is to do this, we need to evaluate the risks and benefits of a medicine to an individual patient. When you want to give a medicine that is unlicensed or off-label or outside the standard practice, you have to do it only if no alternative is available to meet the patient's needs. Now, that is because these unlicensed, off-label and outside standard practice things come in after the drug has been given a particular approval, and the licensing authorities would say, okay, you can use this drug for these conditions because we have evidence. After that, also people start getting evidence for the effectiveness of these medicines. And thereafter, people would say, okay, I'm giving this drug, it is beneficial to these patients, it might work. We saw it increasingly during COVID time because lots of medicines were given off-label or unlicensed for their usual medicine. And if you want to prescribe a medicine like that, it has to be only if you have no other alternative to meet the patient's needs. And to get the best medicine, you need to get the best formulation. If a patient does not have teeth, like in old age, and you want the patient to chew the medicine and swallow, that's not going to work. So you have to give him a formulation which he can use without a problem, maybe a liquid preparation. Then the dose of medicines that you select should be the correct one. It's pointless giving a subtherapeutic dose. We see it very often because you start with a low dose and you forget to bring it up to the targets where you will get the benefit. So selecting the appropriate dose, bringing the targets, the frequency. If you have a complicated regime, that's going to be difficult for the patients to manage. The route of administration and the duration of treatment. Now, all these factors will affect the selection of effective, safe, and cost-effective medicines that are tailored to the individual patient. It's important to adhere to national guidelines and local formularies where appropriate. Now, guidelines are just guidelines. They are there to guide you. It is good to stick to those guidelines unless you have a very compelling reason to do so. I think Dr. Matthias mentioned earlier that there is always help available and you need to call. So if you want to do something outside the guidelines that you're aware of, then ask somebody whether it is okay to do so. And there are formularies available sometimes in local hospitals, which will say, okay, these are the medicines that we have currently in the pharmacy. That's where you need to use those as much as possible. It's important to be aware of the guidance produced by respected bodies. Now in Sri Lanka, Ministry of Health produces guidelines, professional colleges produce guidelines. But as I said earlier, you need to always consider the needs of the individual patient. And of course, select the medicines with regard to costs and needs of other patients. Because if you use the most expensive medicine to treat just 1 or 2 patients, the vast majority of the others will not get the medicines that they need. And you should be able to identify, access, and use reliable and validated sources of information. So I hope most of you, at least all of you, have the British National Formulary, the app that is available, which can be used with Android phones, because it helps you to select the doses and the routes and so on. And you should also be able to evaluate potentially less reliable information critically. One of the biggest sources of information currently is the social media, and that doesn't mean that what it has is really always correct. So you need to be able to evaluate this information critically and use it for your patients. Now, this is the BNF app. It is available in Sri Lanka. I hope you have been able to download it and use it. Write clearly, because prescription is a written document. It's advice and authorization to people. And if it is not legible, it's rather difficult for the person who's reading it to make the correct call. There have been instances where abbreviations have been used in an inappropriate manner, where the prescription has not been legible, and people have still prescribed medicines based on that, and patients have died. And therefore, you need to be aware of common factors that cause medication errors and know how to avoid them. Now, as you know, medication use is by many people. It's not just us. There is us prescribing as medical officers. Then our prescription is transcribed by nursing officers and they bring it to the drug chart. In many countries now, it is the medical officer who has to also bring it to the drug chart. Then, of course, the nurses and the pharmacists are involved with dispensing our medicines, then administration and monitoring. As you can see, I have put a yellow halo sort of thing around some of these. That is because apart from us, others are also involved in these processes. Now, we are also involved with monitoring the medicines that we give and also administration. Sometimes you might have to dispense as well. So this process, as you can see, involves a lot of other people, and therefore the chances of errors chances of an error happening is quite high because it can happen at any of these places. And the most vulnerable for these errors are those like children, elderly, and people with multiple comorbidities. Elderly and children because they have different physiological mechanisms from other adults, and those with multiple comorbidities because they take a lot of medicines and therefore you can always make a mistake. Of course, errors can cause additional hospitalization, loss of income. It might actually cause disability, and it has happened, particularly when you give IVs in the wrong way, and it can lead to litigations. And that is also increasingly common now than it was when we started working as interns. Now that's a prescription that was there from a clinic note. I'm not sure whether any one of you can actually make out what is there, but the pharmacist has apparently dispensed this medicine because they know the doctor who prescribes it and the clinic that the person is working in, and they have said, okay, this is what the doctor is giving. But you know the normal features of a prescription, and I don't think you can actually identify any of these features except the identity of the patient, which I have actually blocked off. I couldn't read what it is. I'm assuming one is atenolol, but it could be this one where my curse is, but it could be anything else as well. So this is very common, extremely common, so common that sometimes you honestly don't know what your patient is taking. So it's important that you write legibly. This is the surest recipe for any medication error to take place. Medication errors happen in Sri Lanka, and this is a study we did in one ward in a hospital closer to Colombo. And there were many reasons for medication errors. I'm not going to go into it, but frequencies were wrong. There were duplications, unacceptable combinations, omissions, caring omissions because the people have been on these medicines and nobody has reconciled the medicines that they were taking. Various other issues as well. So it's important that we avoid prescribing errors because it's a failure in prescribing and the decision-making process, which are errors of omission where we fail to act correctly or we act incorrectly. And it is preventable almost always. And that is why we have to be careful when we prescribe medicines. It could be because we lack the correct knowledge. Of course, that is easily remediable. Once you know your limitations and you don't know something, you can always look up. The other important thing is medical records being incomplete and medical records being not available with the patient. And that is again increasingly common because there is this tendency to retain part of the records in the hospital. And the patient, when he goes to another place, will not know what he has been given, what the conditions are, because the records are incomplete or they are not with the patient. So it's important for us to improve our knowledge, take good histories, good drug histories, and keep good medical records because they're not really for us, but for the next person who is seeing this patient. And if you're not sure of anything, check. There's no harm in checking any of these things. Many reasons for prescribing errors. We might assume the weight in weight-dependent doses. Decimal points, if you don't clearly put the decimal point, it can be a problem. Now, usually the 0 before the decimal point does have a meaning. At least it's important to put the decimal point there. But the mistake, most of the time, what happens is if you don't put the dot here and put a figure here, then it could be read 10 times more than the dose that is required. Lots of abbreviations which are really not acceptable, and brand names, using those of tablet strengths, the tablet numbers or fractions of tablets rather than the amount of milligrams. All these can cause prescribing errors. Deviating from a guideline, remember, is not a prescribing error, and that is allowed provided you know why you are deviating from the guidelines. Adverse reactions or adverse events are also not necessarily medication errors. They can happen, and what is important is for us to know that they can happen and can cause problems. The next important principle when you're prescribing is that we need to monitor beneficial and adverse effects of medicines. And we need to know how to assess these and detect these problems. We need to alter our medicines based on the benefits and the adverse effects. And we also need to know how to report ADRs. And this is how we report. We report to the NMRA. And when you click on the NMRA link, it opens. Okay, I'm not sure whether you can actually see my screen now. Can you see the website? Can you see the website that I'm sharing?
No, madam, no.
Oh, let me see whether I can share that screen. Yeah, that's it. Right. So this is the website that you get connected to at the NMRA if you want to report an adverse reaction. So it asks about your details, the medicine details, and what has happened, and so on. And once you do that, this actually gets flagged back to the NMRA as well as to the faculty, Colombo faculty, which is actually looking at these ADRs. So it's important that we report ADRs so that we know what is happening with our medicines. And if we want to identify a pattern sometimes which is unique to the Sri Lankan population, this ADR reporting is beneficial in that sense. Then of course, communication and documentation is important, and you need to communicate and document why you are prescribing a particular medicine with the patient and their carers and with your colleagues, because they are the ones who are going to follow up on these aspects. Very important, prescribe within the limits of your knowledge, skills, and experience. If you don't know, ask. It is always better to check and ask rather than relying on a memory which is very fallible and make a mistake and which can be harmful to the patient. Ask from the right person, not people who probably will not have the required knowledge. That is also important. So always go to your seniors rather than your colleagues, because they will be able to help out if you don't know. Make sure where appropriate, the prescriptions are checked. And especially if you want to calculate a dose, it is always better to get somebody to double check if that is possible. So those are the 10 important principles that I want to go through to open your minds to, so that you know what you are going to do when you start prescribing. An important aspect that we don't do very often, but is a very important thing, is error reporting. That is, whenever an error occurs, you report. Right? You might give a medicine, you have not checked whether the person has an allergy, and the patient got a reaction. So that's an error, and we report that error. That error has to be reported not to find fault with somebody, or not to say that somebody is at fault and appropriate blame, but as a learning exercise, so that we can see where the system failed and make sure that those problems are corrected so that the error does not happen again. So finally, getting the best of available medicines really is rational and safe prescribing. And avoiding medication errors are important because it can cause harm, it can increase cost, and it can increase hospital stay to the patient. Both of these are possible. It's not an impossible thing, but they only need attention to detail, and we are careful with what we do. The most important message that I want to give you is that you are responsible for what you prescribe and for the prescription that you sign. It doesn't matter whose instructions you are following, whether it is the consultant's order, the SR's order, or the registrar's order. When you write a prescription, it is your responsibility. So even if you have been told to write something that you don't agree with, it is better to check with that person, give you reasons as to why you don't agree, and thereafter make a choice of what to do. Because at the end of the day, you are the final, you have the final responsibility for what you prescribe and you run. You're also accountable for the instructions you give others in administering medicines. So you can't, go away by saying, just because I prescribe, but it's a nurse who gave. It doesn't work that way. It's your prescription. You're the person who's instructing the nurse to give that medicine, and therefore, those are your responsibilities. So that's all from me. I'm quite happy to take questions. I think we have about 2 minutes for questions. Do you have any questions? I'm quite happy to take any questions that you have. Any questions?
If you all have any questions, use the chat box also. If you can unmute. Right. So in absence of questions, we would like to go to the next lecture. So thank you, Professor Chandani Maniga Tunga, for that comprehensive lecture on prescribing of essential in prescribing. Thank you once again, madam. So
thank you.
So next up is initial management of seizures by Dr. Ranga Gunasekara, consultant physician at DGH Nuvareli. Over to you, sir.
Thank you, Roshan. Can you all see my presentation?
Yes, I can see and can hear. Might have to make it full screen. That's all.
Okay, perfect. Thank you. Okay, good morning to you all. I'm Dr. Ranga Gunasekara, consultant patient from DGH Nuvareli. I'll be talking to you regarding the initial management of seizures. So, first of all, I would like to go through the definitions. So what is epilepsy? Epilepsy is the syndrome of 2 or more unprovoked seizures that occur more than 24 hours apart. What are the unprovoked seizures? Unprovoked seizures are distinct from provoked seizures. Provoked seizures are due to an acute condition such as toxic or metabolic disturbance, immediately antecedent to head trauma or very recent acute stroke. The term unprovoked seizures refers to a seizure of unknown etiology as well as one that occurs in relation to a pre-existing brain lesion or progressive nervous system disorders. Status epilepticus. Status epilepticus is 5 minutes or more of a continuous seizure activity or recurrent seizure activity without return to baseline. So without return to baseline means the patient has been GCS 15, patient has been talking, eating, walking about, but the patient is not returning to the baseline, patient is drowsy. So you can diagnose a status epilepticus if it persists more than 5 minutes. So clinical diagnosis of an epileptic seizure requires a detailed history taking, ideally an eyewitness account of the seizure. This is very, very important because it is a history-based diagnosis, because you won't get much clinical signs and symptoms on your examination. You need to have an eyewitness account. If possible, always make a call to a relative, find the eyewitness, and have a eyewitness account as well. Because you need to recognize the pattern of that seizure for you to have a better diagnosis. So always remember that it's a clinical diagnosis. And evaluation with 12-lead electrocardiography is essential in a patient who has had a first seizure or an unexplained blackout spell. These are sort of pearls that I wanted to highlight. Any patient who has coming with a blackout or suspect of seizure, you need to have a 12-lead electrocardiography, 12-lead ECG to exclude any or to identify any cardiac arrhythmias or cardiac cause. And remember this one as well, in children and teenagers, intraictal electrocardiography, ideally within 24 hours after first seizure, is particularly important because you will be dealing with 16, 17-year-olds, 18-year-olds. If you can arrange the EEG within first 24 hours, that would yield best results rather than delaying it. So all patients who have had a suspected focal onset seizure should undergo detailed magnetic resonance imaging. That means if the patient has a partial seizure or a seizure was focal onset rather than generalized onset, they need to have an imaging according to the availability of the imaging. And patients who have had an epileptic seizure should be informed about the factors that may provoke seizures. So when you are discharging patients or when you are counseling patients, you need to make sure what are the factors that provoke seizures and what are the things they need to avoid doing to reduce the risk of getting injured after having occurring a seizure. So data from long-term pharmacological studies, first line. So usually in the clinical setup, we wait for second seizures to start the patients on anti-epileptic treatment. However, that changes if the patient has a high risk. Say, for example, patient is occupied with a high risk occupation, patient has family history of epilepsy, patient has tendency to develop a seizure because of there's a prior lesion. So in those cases, in the first instance of itself, we are going to start the anti-epileptic treatment. So for the focal onset seizures, either lamotrigine and levetiracetam is the drug of first choice. And the generalized seizures, you can either use sodium valproate or levetiracetam, depending on the availability. So history and exam, it is the most important part of the of any patient who comes with a seizure, because you need to categorize whether it's a seizure or a syncopal episode or a psychogenic non-epileptic seizure or pseudo seizure in the common term. So if it is an epileptic seizure, you need to find out whether it's a provoked or unprovoked. It's a syncope, whether it's a reflex syncope, orthostatic, or a cardiac. I'm not going into much detail of the history and exam because the topic is regarding the management of seizures. So then again, you need to find out whether this is a true seizure or a pseudo seizure, depending on the seizure characteristics or depending on the characteristic of the history that you are going to obtain. So whether it's aligned with the pattern that you recognize as a seizure, whether there's a lateral tongue bite, whether what duration was it, whether there's a post-ictal phenomena associated with it, whether there are substantial injuries associated with the episode, so that bring you towards the true seizure. Whether it has occurred during sleep, that is a sinister sign of a true seizure as well. So those things you need to ask from the history to clarify whether you are dealing with a true seizure or not. This is the same thing that I talked about. So why do you need to know the etiologies? Because when you are approaching a patient with seizure, yes, we're going to go ahead with the initial management, but you need to understand why this is happening or why this is occurring. So it could be due to metabolic disturbances. It could be due to any CNS pathology, central nervous system pathology. It could be an ICH, SAH. It could be a stroke. Following that, patient has presented with a post-stroke seizure. So it could be a space-occupied lesion or a CNS infection, right? Or else any drug which has a seizure property as a side effect. Or it could be an alcohol withdrawal. It could be a drug addiction patient who has had comes with a withdrawal. So you need to take a detailed history regarding what sort of a thing that you need, what you are dealing with. Or it could be something like cerebral hypoxia, hypertensive encephalopathy. The patient has very high blood pressure and coming with seizures. So it's an hypertensive emergency. Or something like PRES. Or it could be a rare variety like autoimmune encephalitis or a paraneoplastic syndrome. So you need to take history in relevance to all those aspects for you to find out as to why this seizure is happening. Because for you, although you control the initial step, for you to have a good control of seizures or to treat the seizures, you need to find out what's the etiology behind seizures. So, on the other hand, those are the acute processes. The chronic process could be epilepsy, patient coming with breakthrough seizures. So it could be a chronic alcohol abuse patient who's coming with withdrawal seizures, CNS tumors, or CNS pathologies. And the other variety is of a patient who's already on treatment coming with a withdrawal seizure or a new seizure. So find out as to why this is happening. It could be a recent medication changes which has happened in the clinic or as an outpatient or due to a recent admission. There could be an omission, reduction, or adding a new drug to the existing regime. So it could be a change of medication. So find out as to why, whether there was any changes to the existing medication. Or it could be a intercurrent illness. So it could be a patient having a UTI, lower respiratory tract infection, or any sort of an infection which has precipitated the seizure. Or a metabolic derangement. Patient has had a diarrhea, vomiting due to some other illness, and patient has had electrolyte imbalances which has precipitated the seizure. Or a progressive disease, so initially which has not been identified, which has resulted in a seizure, and there's a progression of such disease, something like autoimmune encephalitis. So the history is very important to find out these facts, right? When you are the first one who's encountering these patients at first. So take those details. So don't wait till the senior house officer, registrar, or senior registrar, or the consultant comes in. Take these, remember these elements and ask about these things and get the full history. Okay, so far I think I have covered the basic theory part. So this is the history. With that, I'll be going through the management of the seizure. An 18-year-old woman is brought to the emergency department after having had a seizure. She was up late with friends the night before and drank some alcohol. Shortly after waking this morning, she collapsed without warning, injuring her face. Her boyfriend witnessed her having a generalized tonic-clonic seizure with cyanosis during which she bit the side of her tongue. Her first memory was waking in the ambulance. She has had no previous seizures. Specifically, she has not had any involuntary jerks of the arms, legs on awakening. Blank spells, sensitivity to flashing lights. So this history per se is an 80-year-old woman who had a first seizure, and classically it was described by an eyewitness saying there's a generalized tonic-clonic seizure, and there was a cyanosis involving that episode, and she had a lateral tongue bite. And she has definitely lost her consciousness. She could only remember she's in the ambulance at the time of waking up, and she had no past history of seizures, no other history suggestive of any cardiac or a syncopal episode. So how do we approach this patient? It's similar for every emergency. You need to assess the patients according to A, B, C, D, E: airway, breathing, circulation, disability, and exposure. So always approach the patient safe. So you might encounter a patient who has had a seizure while in the bathroom. You might encounter a patient who has had a seizure while walking in the corridor in the hospital. Approach the patient safely. Make sure that whether there's any equipment or any stuff that is there which could harm the patient, remove those things from the that particular area and keep the patient in a safe environment. Turn the patient into left lateral position. If there are secretions, suck out the secretions and get the patient to avoid any further injuries. Make sure as soon as you see the patient, call for help, because you won't be able to manage this patient alone. Call for nurses' help, call for other colleagues to come in and help, and delegate the tasks according to the requirement. So you could ask the patient to, if the patient is not cannulated, get the patient in IV access, get the blood draws for the particular investigations, relevant investigations, somebody to get the oxygen and keep the oxygen, high flow oxygen running, suck out the secretions so that get somebody to get this machine and suck out the secretions and keep the patient in a safe position. So get the team involved, because that is a very important part of management of an emergency. So airway, so you need to make sure that the patient is continuing to have a good airway, patent airway. Check whether there's an stridor, check whether there's an secretions, suck out those secretions, position the head and the neck to have a patent airway. Check the patient is breathing. If facilities are available, connect the patient to the cardiac monitor, attach the ECG leads, attach the blood pressure monitor. So continuously monitor the patient during the episode. Arrange an ECG, blood pressure, and check the oxygen level. If you have the IV access, get the IV access, run IV fluid. If you don't have an IV access, you can even access through the intraosseous line. Check the capillary blood sugar. If there's hypoglycemia, which is a common occurring, treat the hypoglycemia immediately. Check the temperature. If there's a running temperature or hypothermia, it could be hyperthermia or hypothermia, because the sepsis could be the result of the seizure. Because sepsis can manifest as a seizure, so you have to take the blood cultures and start on empirical IV antibiotics. So it could be CNS infection. If you're thinking of CNS infection, you need to start the IV antibiotics empirically to cover the CNS infection. At the same time, get a nurse or your colleague to draw blood for necessary relevant investigations. Full blood count, basic metabolic panel, the sodium, potassium, and calcium and magnesium. If there's hyponatremia, then you can consider starting 3% sodium chloride, but always get your seniors involved if you are going to that step. And if the arterial blood gas is available, get the ABG, BBG done, because you can identify many things from the arterial blood gas. If there's existing metabolic acidosis, if there's existing electrolyte imbalances, so you can get much information from an ABG. If that is relevant, if you are suspecting an acute stroke or acute ICH, so you can, if the facilities are available, you can go ahead with the CT, but make sure the patient is stabilized first before sending for further investigations. And the patient needs to be continuously monitored during the process, during the initial management. So drugs, if the lorazepam is available, it's 4 milligram IV. You can repeat it every 5 to 10 minutes. So if the seizure is not controlled, you can repeat lorazepam 4 milligram IV every 5 to 10 minutes. Make sure that you have a record of patient does not have any allergies or anaphylaxis in the past. According to that, prescribe the medicine. Or you can give midazolam 0.2 milligram per kg IM, maximum 10 milligram per dose, or diazepam, which will be available in most of the hospitals, 5 to 10 milligram IV, or 20 milligram rectal if you don't have an IV access. Midazolam, again 10 milligram IV, intranasal you can be given, it can be given buccal, or through the buccal pathway also you can give it, right? And at the same time, if the seizure is getting prolonged, you can, if you have IV levetiracetam, that you can give 1 to 2 grams as well. And make sure if the patient is, once you give lorazepam, once you owe midazolam or diazepam for that matter, if the seizure is not settling, make sure that you are calling for help, because now you are going to deal with a status epilepticus which need further management steps as well as experience to manage this patient. So get your seniors involved immediately if the seizure is not controlling with the initial drug prescription. So what happens if the patient is not controlling with the initial medication? There are few options that you have. You can load the patient with phenytoin. This is status epilepticus management. So 20 milligram per kg, this is given over 15 to 20 minutes. Or phenobarbital, 20 milligram per kg, that is intravenous. Or you can give IV levetiracetam, 1 to 3 milligrams. And keep it back in the mind, if there's hypoglycemia, correct it. At the same time, if the patient has poor nutrition or prior history of alcohol abuse or alcohol withdrawal seizures, start on IV thiamine at the same time, 250 milligrams slow infusion. But make sure that you correct the glucose first and then the thiamine. Right. So even if you are giving this treatment, still the patient is not under control, this is beyond your scope of management. So get your seniors involved, get your consultant involved. This patient needs to be paralyzed and ventilated electively, because we need to continue control the seizures of this patient. So there onward, it is the ICU management. You can use propofol or phenobarbital or midazolam infusion for that matter to control the seizures. Right. While managing this patient, remember to give hyperoxygen, because these patients can develop cerebral edema. This patient can develop cerebral damage. These patients can develop cerebral venous thrombosis or hemorrhage or infarction as a result of seizure. So if the patient is not recovering with your treatment, so you need to find out whether these complications arise as a result of the continuous seizures. At the same time, patient can develop hypotension, any cardiac arrhythmia or cardiac shock or aspiration pneumonia during the seizure. So make sure if that is developing, you are acting accordingly, give fluids, get the cardiac arrhythmia under control. If there's cardiogenic shock, fluids and inotropes, so these things needs to be managed with the help of your seniors. So at the same time, when the patient develops a seizure, they can develop systemic complications as metabolic acidosis, they can have rhabdomyolysis, electrolyte derangement. So check whether the patient has developed these things, order the investigations accordingly to see whether the patient has developed these complications. And the patient can even have a fracture. So you need to attend to that as well. Right. So the take-home message is make sure that you are doing these things according to the plan, as well as managing the initial seizures, find out the reason as to why it's happening, try to treat the reason or the etiology at the same time, try to minimize the complication. If the complications are arising, or if the patient has developed complication, you need to treat the complications as well. I think I will wrap up from this moment. If there's any questions, I would like to take them now, because we'll have another 5 to 6 minutes. Are there any questions? Does anybody have questions? Roshan, are you there?
Yes, I'm here. Sorry.
Are there any questions? No. Does anybody have questions?
Yeah, we have another about 6 minutes left. So anyone having questions, you can unmute and ask or use the chat box.
Okay, in the absence of any questions, I think I will wrap it up, and I can hand over back to you, Roshan.
Right. Thank you very much, sir. That was Dr. Rangagunasekara, consultant physician at DGH Noor Elias. So the next up is we are having a tea break for half an hour. So 10:30 we'll start again. Tea break. Thank you, sir, once again. So next lecture is on leptospirosis by Dr. Kemind Tilakaratne. I think, are you there? Oh, So we will take the attendance in few minutes. So make sure that you all join. Attendance link will be open for few minutes, something like 5 minutes. After that, we will not company any submissions after few minutes. So make sure you all submit timely. Because there are only 230 here. So others, I don't know what happens. Good morning, sir. I have given the introduction. We can start.
All right. I think
So I have given the introduction.
yeah, that's fine. Yeah. Can you hear me?
Yes, I can hear. You need to share the.
All right.
We can't see you sharing.
All right. I can start. All right. Okay.
Right? Can you see? Just hang on.
Yes, sir. Need to make it full screen. That's all.
Yeah, yeah, right. Okay. Yeah. So I hope now it's clear, no?
Yes, sir.
All right. Okay. Can I start or
Yes, sir. You can start. Yes.
so there won't be any interaction as such, no? So shall I start now?
Yes, sir. We can start. Yes.
All right. Okay. Good morning, everyone. First of all, I would like to thank the Sri Lanka College of Internal Medicine, as well as the Ministry of Health, Sri Lanka, for giving me this opportunity to talk to you all on the management of leptospirosis. So I will try to go through, the leptospirosis important aspect in the clinical management. So, yeah, this will be the outline. So introduction and epidemiology. I will be touching on pathogenesis and then, of course, clinical presentation, diagnosis, management. If time permits, I will discuss complication and how to manage them, right? So as you all know, leptospirosis is a global zoonotic disease and caused by spirochetes of the genus Leptospira. If we go back to history, it goes back to 1885. A scientist called Adolf Weil described the clinical hallmark of the disease, splenomegaly, jaundice, and nephritis. Now we call it Weil's disease, which is the severe form of disease with fever, jaundice, aka shock, and pulmonary hemorrhages. Now we do see this sort of cases nowadays as well. I don't want to talk to you about, microbiological aspect, but as you all know, Leptospira includes more than 20 species, and some of them can be non-pathogenic to human beings. Some can be intermediate pathogenic, and some can be pathogenic to human beings. So out of intermediate and pathogenic species, there are more than 250 zeros have been identified. Now, how do we get the infection? That is what important for us. Now, rats, dogs, cattle, pigs, they can transmit the disease to human beings, but there are more than 100 different mammals can be infected, right? When we talk about human transmission, it happens when susceptible individuals come into contact with contaminated animal urine through the surface water, moist soil, other wet environments, or into direct contact with urine or other excreta like placental product. That means, if an animal is infected with Leptospira, if they deliver a baby, especially mammals, there can be placental products. So if we happen to contaminate with that, we can get the infection. So this slide summarizes everything because you can see how we are infected. So there are so many ways by which we can be infected through contaminated water or directly through the contaminated excreta, or sometimes with a lot of mammals. We have very close association with dogs, cattle, and sometimes pigs also can be a source of infection for human beings, right? Now, when we talk about types of transmission, there are three types have been recognized. One is called epidemic, where you get seasonal pattern in distribution. For example, nowadays we are experiencing what is called monsoon rains and also floodings in southern part of our country. I'm sure we will get a lot of cases after floods is over. So that is what is called seasonal. So we get some sort of pattern. Endemic means that transmission is seen throughout the year. If you have, a satisfactory environment for them to transmit the infection, like, tropical humid environment and poor sanitation, uncontrolled dog population, especially in some countries like some part of India, even our country, right? Sporadic means you get transmission sporadically, not throughout the year, or there's no season pattern. So, for example, those who are working with some high risk exposure, occupations and poor hygiene, slums, and some outdoor activities like recreational activities also can, be a source of infection, especially military people, because they are exposed during their jungle training. They have to cross, some small streams. They have to work in, muddy areas, marshy lands, and so on. So you can get, sporadic cases with this sort of exposure as well. Now, as you all know, it does not only affect the rural population, it can affect urban in industrialized countries and even in developing countries like ours. We see a lot of cases throughout the year. Now, when we talk about socioeconomic status, actually it has been clearly shown that it is associated with poor socioeconomic status, especially because of the poor hygiene and overcrowding, right? Now, this is one of the important study done in our country. Why I selected this one, just to highlight you all the case fatality rate in our country. Now, if you go through this study, you can see they have demonstrated case fatality ratio between 2 to 3% in all cases. But importantly, if they develop any complication, it can be even high as up to 33%. So that is what is important for us to recognize them early, treat them early. We should be able to prevent the complication, because if they develop complication, they can have higher mortality. 1/3 of will die, right? Therefore, it is very important. So you will be starting your internship sooner. Always try to, prevent deaths, morbidities in these patients, right? Now, again, same study, you can see the spatial distribution in our country, right? Started from 2008 to 2015. Now, if you look at the pattern, these dark areas represent higher number of cases. You can see throughout our country we have been seeing the cases, but except northern part. But in even 2015, this one part, that is Mana, is affected. I don't know the reason, but you can see most of the areas in the country is affected with leptospirosis. Now, this is the area Sabaragamo. Nowadays we are having some cases in our area as well, and I'm sure we will get a lot of cases in other part because of flooding, right? I'm just touching upon the pathogenesis. Now, leptospirosis infect human through the mucus, or they can get into through our mucosa, through this damaged skin. And organism resist innate immune response. That means it affect actually complement mediated immunity in our body, and they can proliferate in the bloodstream or extracellular within the organs, and then can disseminate hematogenesis to various organs, right? When we talk about incubation period, it can go up to generally 2 weeks, but sometimes maybe 3 weeks. The important thing, you can isolate organism from blood during first 10 days of the illness. So if you have facilities, we can take blood cultures to a specific medium, so we can isolate the organisms, right? Now, when we talk about clinical manifestation, I just want all of you to focus on this slide, because you might see a lot of cases with fevers, right? When you start internship, you are the first contact doctor. So there will be a lot of cases with fever. So coming into your ward, so you are the first contact doctor, you need to take good history in these patients, because if you miss these cases, patient can develop complication, even they can die. Most of them can have very, subclinical, milder form of disease, so they can have non-specific symptoms like, any other viral or febrile illness, up to Wales disease or severe form. So that means it is a spectrum of disease similar to, dengue fever. So, and there are two, patterns have been recognized in leptospirosis. One is called leptospiremic phase, where patient can present with fever and any other constitutional signs and symptoms like, arthralgia, myalgias, body aches. Sometimes they can have respiratory symptoms as well as some skin manifestations like erythematous rashes and so on, conjunctival injection and jaundice. So this phase can last up to 1 week. After that, they go into what is called immune phase, where most of the patient develop complications, right? So we should not, let these people develop complication. Unfortunately, some patients are admitted later on with the immune phase with complications. So symptoms are related to their organ or system involvement. That means, for example, if lung is affected, they will have cough, SOB, hemoptysis, and so on, right? Like that. So what are the differential diagnoses? This is very important. That's why I'm telling you. So the leptospirosis can mimic any of these illnesses, right? It could be, representation can be similar to very, viral illness. It can mimic dengue fever. And also typhus is one of the differential, because patient with fever and skin rash coming in same sort of distribution. So you have to think of lepto, and the typhus is one of the differentials. Now, patient with leptospirosis again can come to you with features of meningism. it may not be typical bacterial, but it could be a case of, leptospirosis. So even it can present as sepsis. So again, patient just coming with pure sepsis could be a case of leptospirosis, right? Typhoid, one of the differentials, and also hantavirus, one of the important thing, because patient with hantavirus, they can get pulmonary renal involvement as in case of leptospirosis, right? Sometimes we do see cases coming with, just pure, liver involvement, mimicking viral hepatitis. Don't think these cases are just pure viral hepatitis, because it could be a case of leptospirosis. And lastly, you need to consider non-infective causes as well, because sometimes SLE, vasculitis, or leptospirosis can mimic these conditions. So you have to be aware of those things. So I'm very concerned about clinical picture, because you all have to go through these patients, take detailed histories. Now, this is very important slides, again, case definition, because most of these cases are suspected cases. So we have to notify them. It is part of your job as intern doctors to notify them. So how do you define a suspected case of leptospirosis? Any patient coming with acute febrile illness with any of these symptoms, right, which I have described earlier, with a history of exposure, which is very important. That's why you need to get good history and evidence of organ involvement. Then you have to suspect leptospirosis clinically, right? And this is called confirmed cases with some blood tests, like, can do cultures for pathogenic leptospirosis or positive PCR, and a single titer of MAT means microscopic agglutination test, more than 1 in 320 or 4-fold rise or seroconversion, which I will describe later on, right? Now, this is very important slide. Again, history of exposure for leptospirosis. So you as interns should take a good history, right, in relation to the occupational history. Now, high-risk occupations like such as paddy farming, construction work, gem mining, sand mining, and working in special places like Kirakotu, Kohilakotu. So you need to ask about these things, right? And recreational activities can also increase the risk. So especially in outdoors like paddy fields, muddy grounds, and even whitewater rafting can, precipitate. Now, suppose you get a patient with fever who has had a, rafting in Kitulgalo somewhere, coming with fever after a couple of days or weeks. So you need 1 week or so, you need to think of lepto, right? Don't think that it is not transmissible in clear water. It can happen, right? Contact with potentially contaminated water sources such as cleaning drains, wells, bathing and washing in small water streams, rivers and lakes, and flood water, right? And again, contact with animal or animal tissues such as cattle, buffalo, and especially animal handlers, veterinarians, butchers, rodent workers, and so on. So you have to have a good, you have to take a good detailed history, and contact with water contaminated with urine from any animal known to be a reservoir species is the most important risk condition to transmission. So that is why I'm telling you all to take good history. And rats, other rodents, buffalo, cattle, and dogs and pigs are important for us, right? Presence of breast skin it increases the risk of infection in compared to intact skin, right? So then how do you diagnose these cases? Now, you need to have what is called high degree of clinical suspicion, as I told you earlier, because they can present with non-specific symptoms, right? So detailed history is important, taking into consideration of exposure history, which I described earlier. And then you need to assess them. You have to do a physical examination, which is very important, because suppose you might get a couple of patients with fevers, and you need to identify who are the sick patients, right? Sick patients, you need to give more attention. So do a physical examination, focusing on the level of hydration. That is very important, general condition of the patient, and then of course whether he's having any skin rashes, jaundice, and then of course other vital parameters like pulse, blood pressure, saturation, and you need to take a look at the organomegaly and so on, right? So you need to identify who are the people who are sick and who are the people who will develop complication. Not all patients will develop complication, but if you miss any of them, they can end up with complication, right? So what are the tests you can do? So basic tests like full blood count, there can be neutrophil leukocytosis, thrombocytopenia, and leukopenia later on, and features of anemia, and even they can develop what is called MAHA, microangiopathic hemolytic anemia, right? Urine is very important. Simple test you can do, urine full report. There can be leukocytosis, red cells, and especially granular cast, proteinuria, and bile in the urine. So this is one of the conditions where you can get a lot of abnormality. So start with simple test, and you have to do renal function, creatinine, blood urea. If there's a discrepancy between blood urea and creatinine, you have to suspect, dehydration. Electrolyte abnormalities like hypokalemia, hyperkalemia, hypomagnesemia, even calcium can be low. I will tell you what are the reasons for hypokalemia. And there can be abnormal liver test, high transaminases, and both conjugated and unconjugated levels can go up. And you can do some inflammatory markers, CRP, which can be elevated. Chest X-ray is very important, but actually at the beginning, it can be normal. But with time, there can be a lot of changes. If your patient is getting symptoms suggestive of pulmonary involvement like cough, SOB, hemoptysis, please do repeat the X-ray. You just don't, wait, because if first X-ray normal, after a couple of days, you can have so many changes like alveolar infiltrates, interstitial infiltrates, and sometimes small nodular infiltrates, pleural base densities, and even features of ARDS, because they can develop ARDS and pulmonary hemorrhages. And there can be abnormalities in cardiac troponins if the myocardium is involved. They can develop complication, and there can be ECG abnormality as well, right? Now, this one shows some X-rays, series of X-rays. X-ray A appears normal, but you can see B a little bit, there are small densities, but later on C, bilateral involvement, right? So fourth one after treatment. So similarly, there can be changes unilaterally also. CT is helpful in the diagnosis as well. So that's why you need to do serial X-rays if you suspect pulmonary involvement in this patient, right? What are the other specific tests? So one is you can do dark ground microscopy, but usually we don't do in clinical setting. PCR-based assist can be done, and which is very specific, and it has high sensitivity if you do early in the disease. But the gold standard is the cultures, blood or CSF during first 10 days of the illness, right? That is very important. Urine culture after 1 week, but whatever the test we do, cultures, it takes 2 to 4 weeks. So we can't wait until blood culture reports are available. Other thing, you have to have an important medium called EMJH medium for them to grow. They will not grow in normal culture bottles. So unfortunately, I'm not sure whether it can be done in our country. Probably in research setting we can use, but most of the time we use what is called MAT. MAT means microscopic agglutination test. This is the serological reference test recommended for leptospirosis in our country, right? So you can take bloods after 7 days. Don't take before 7 days because this can be negative. But if you are taking bloods before 7 days, you have to do another sample at least after 2 weeks or convalescent period to see whether there's a seroconversion or rise in titer. If the rise in titer is there, you can diagnose, or even higher values of single titer could be diagnostic in our setting. Now we have got MRI in our country, so they do these tests. We have got 20 common locally prevalent serovast, so they use those serums for these tests. So single titer, high titer could be used, or else you have to have 2 samples after 2 weeks of illness. Initially one first sample, and then you have to take another sample. If there's a 4-fold rise in titer, or if there's seroconversion, it is diagnostic, right? And ELISA-based tests are available. And other important CSF we can use. It can be used actually. CSF pleocytes, that means presence of neutrophils is important, and it can be very high in some cases with predominant neutrophil polymorphs can be predominant, right? Now this slide is very important. It summarizes everything. Now if you think about this one, incubation period, I told you about, it can generally 2 weeks, but it can go up to 3 weeks. And during acute stage, you can take blood or CSF cultures, and after 1 week, you can take urine culture. But in some cases, it can last for weeks or even months. Some chronic, convalescent shedders, so they can shed the leptospira even though they are asymptomatic. Sorry, they can transmit the disease, right? Now, antibodies generally, appears after 1 week. Now, there are 2 patterns. Now, early treatment will blunt the immune response, so the antibody response will be less compared to a person who is not treated with antibiotics. So he will have high antibody response. It does not mean that we should not treat because the patient will end up with complication, right? So cultures, I told you. So this is an important slide. Now, when we talk about management, right, this is very important for you all because you will be working as interns in the future, right? You have to recognize who are the sick patient. You have to identify, put them into a place like where you can observe, for example, H2U. You can monitor them. You need to monitor their vitals like pulse, blood pressure, saturation, level of consciousness, urine output, and as well as sometimes, capillary refilling time, and write clear instruction depending on the patient condition, whether hourly, 2 hourly, 3 hourly. That is very important, right? Don't write vaguely, monitor the patient, write clearly in the BHC so that nurses can do it well, right? Now, fluid management is very important in these patients because strict monitoring is important. You don't have to catheterize all these patients because some patients can manage themselves. So if you suspect AKI, better to catheterize. And now you need to assess volume status. I mentioned you all earlier because if you suspect dehydration, you have to start IV fluid. You might have to give boluses depending on your patient, but if patient hydration is adequate, you can give generally about 2 to 2.5 liter in adults per day. But there's a tricky situation where a patient can be oliguric. So you have to differentiate whether this is due to high, dehydration or whether this is due to AKI. Because if it is due to AKI with oliguria, if you give too much of fluid, patient will end up with fluid overload later on. So that is why you need to assess clinically whether they are dehydrated or not, right? In general, an oliguric patient, the intake on a particular day should be equal to previous day output, and estimated insensible loss should be added, right? That means you go with the first 24 hours urine output plus insensible loss. That is the minimum requirement in oliguric patient without any dehydration, right? If you don't have 24-hour value, you can go with previous hour value plus addition of insensible loss. You need to calculate per hour insensible loss, right? If you think patient is dehydrated, you can try a couple of boluses and see the response. If output increases, you are happy. If not, just reassess, see whether patient is having signs of overload, right? And management of electrolyte disturbance, again, very important. They can develop various electrolyte disturbances. Potassium can be low or high, depending on the type of AKI, or they can have, low calcium, low magnesium. So you need to correct them with intravenous or oral therapy, whatever, depending on severity. Diet generally now, even though this says low protein, nowadays actually AKI, you don't have to restrict too much, but potassium should be restricted. If potassium is high, low potassium diet is recommended. Generally, we don't expect you all to avoid any nephrotoxic medication or hepatotoxic drugs, especially, NSAID should be avoided. Don't prescribe NSAIDs for any patient with fever. That is one of the important things. So you might see patient is having very high fever spike, does not respond to paracetamol. Don't go prescribe diclofenac or whatever, because it will be drastic, it will affect your patient's outcome. Don't do that, please, because it is happening very commonly in outside of the hospital. And other thing, patient with diabetes, you have to stop all, oral hypoglycemic, and we might have to use insulin as well, right? Now, how do you determine whether these patients develop a complication? Now, there are no, prediction charts we don't have, but some things like, old age, chronic alcoholics, and presence of leukocytosis, low packed cell volume, and hyponatremia, and hepatic elevated transaminase predicts poor prognosis, right? You need to give more attention for these patients, right? How do you treat? You can start with antibiotics. So better to start early for out of the illness. I told you there are 2 phases. During leptospiremic phase, if you start antibiotic, they will have better outcome. But unfortunately, if you start antibiotic during immune phase, there may not be a place. So try to start antibiotic early. Drug of choice is penicillin, but due to various reasons, especially problem with ST and allergies, we tend to start now 3rd generation cephalosporins. So you can start with ceftriaxone or cefotaxime. Intravenous antibiotics can be changed to oral later on once the patient is stable. In milder case, you can use doxycycline 12 hourly for 7 days generally. The other thing, if your patient is sensitive to penicillin or cephalosporin, you have to use doxycycline. And during pregnancy, we can't use it, and also breastfeeding, and children below 12 years, you have to use alternative drugs like, penicillins can be used in pediatric age group, but if they are sensitive, you have to use azithromycin or clarithromycin, right? Now, who are the patient and who needs intensive care? Because some of them can develop complications, so we have to put them into ICU. So some of the indications are here: hemodynamic instability, tachycardia, presence of hypertension, and drop in mean arterial pressure, and evidence of poor peripheral circulation, low saturation, and tachypnea, evidence of pulmonary hemorrhages, ARDS, significant spontaneous bleeding, altered level, reduced level of consciousness for that matter. So you have to be more vigilant. They might need ICU care. So there's a guideline actually, which is available in all the hospitals. So go through this one kindly when you are going to start medical appointment. That will be helpful. And you as house officer need to notify all these suspected cases or confirmed case. There's a special notification form. So it is your duty to do that one. And then the MOH will send a field team to do field investigation, which is very important for the epidemiological purposes. Chemoprophylaxis can be given in selected high-risk patients, high-risk groups like farmers in seasonal manner. So it is done by the field doctors, MOHs. They are doing a very good job. Now, a few words about complication. Now, renal is one of the deadliest complications. It can vary 40 to 60%, depending on various studies, and mortality is quite high compared to other patients. As I mentioned earlier, pulmonary complication, 1/3 would die. Similarly, AKI patient can die, right? 22%, so significant mortality. There are various theories have been postulated for the AKI. Now, two important patterns have been recognized. One is called acute tubular interstitial nephritis. Other one is acute tubular necrosis. That when you have acute tubular necrosis, they can have what is called tubular dysfunction. That's why they have generally non-oliguric renal failure. Even though their output is high, that is because of tubular dysfunction, they will lose a lot of solutes as well as urine, so they can't concentrate. Because of that, they can have high urine output, but they will not have, the creatinine will be high because of that, right? So other pattern is interstitial nephritis. There can be involvement vascular as well. So AKI is usually non-oliguric and hypokalemic. That's why they develop hypokalemia. So management, you need to correct electrolyte abnormalities, fluid replacement, and correction of other metabolic abnormalities. And sometimes some patients need renal replacement therapy. Few words about pulmonary complications. There are two important patterns. Again, pneumonitis with or without pulmonary hemorrhages. Some can develop acute respiratory distress or acute lung injury. Most of these patients need ICU care. Management, again, oxygen therapy, mechanical ventilation, plasma exchange is very important. I just want to highlight that fact. Now, patient with pulmonary hemorrhages, we can give plasma exchange. It has been shown to reduce mortality significantly. Even there are evidence in our country. There have been many studies done in our country. So this is very important. If you get a case with pulmonary hemorrhage, if you don't have facilities, please transfer them to a center where facilities are available. If you have facilities, discuss with a transfusion physician, arrange plasma exchange early. That will prevent deaths, right? Now, there's a place for methylprednisolone. Some clinicians use in early course, may be beneficial, but actually evidence is lacking for that. Cardiac complications, they can develop pericarditis or myocarditis, and there can be various abnormalities in the ECGs, rhythm disturbances, so on, right? Now, hepatic complication, again, is one of the problematic situation in leptospirosis. Now, there's a classic leptospirosis severe form is called whale disease, where they can develop fever, jaundice, and splenomegaly. They can get what is called cholestatic picture with elevated bilirubin, direct and indirect both. But importantly, these patients don't have very high elevation of hepatic transaminase compared to acute viral hepatitis. They can get thousands, but here, of course, hundreds. So that is how you might differentiate clinically, but it is not hard and fast rule. Now, how do we manage this patient? Actually, we can give again supportive care, correction of whatever metabolic abnormalities, and there's a place for intravenous N-acetylcysteine. In any case of acute liver failure, even we use in dengue cases, not only in paracetamol, any patient with acute liver injury, you can use intravenous N-acetylcysteine. Similarly, in cases of liver failure due to leptospirosis. So finally, hematological complication, they can have various hematological manifestation, minor bleeding to life-threatening, fatal hemorrhages in lung and even GI tract. So depending on that, you have to manage accordingly, because there can be a lot of abnormality in the coagulation cascade, and patient can develop, DIC and various complications, HUS and TTP-like picture. So management, basically, you have to discuss with the hematologist or transfusion physician, plus selective blood or blood product transfusion, depending on your patient clinical condition. So I have written here some of them: platelets, plasma product like FFP, blood and prothrombin concentrate complex, cryo, fibrinogen concentration. A lot of treatment options are available, but we have to tailor according to your patient situation, right? So finally, these are the take-home messages I want all of you to concentrate, right? Leptospirosis is a common zoonotic disease in Sri Lanka. It can be presented with wide array of symptoms, signs, and you need to have high degree of clinical suspicion, because if you don't anticipate, you might miss them, right? Supportive care, close monitoring, and early use of antibiotics can prevent complication and mortalities. Early recognition of complication and appropriate management is vital in improving outcome. And chemoprophylaxis is given for high-risk groups in the appropriate clinical setting. Notification of all suspected and confirmed cases is important for epidemiological perspective. Right. Thank you very much for listening. So that is the end of my story, right?
Right. Thank you very much, sir. If you're having any questions, we can take few
So yeah,
minutes to.
if you have any question, you can ask. I just rushed through the leptospy because of time factor.
In the meantime, the next lecture is by Dr. Tushari Vanigaratna, consultant physician, on the topic of anaphylaxis.
Some questions. Hello, can you hear me, Roshan?
Yes, madam, can hear you.
All right, okay. I will share
Yes,
my
yes, slides
screen
also.
and start the lecture. Right, sure. Yeah. Roshan,
Yes, madam.
I cannot share my screen.
Madam, first open the presentation.
Yeah, I have
Then,
already opened it.
go to screen sharing.
Yeah.
Select the relevant presentation. And it becomes blue and share it, madam.
Can you see it now?
So opening up, not. Right.
Right. You go to the slide.
Madam, presentation close කරලා ඊට පස්සේ ආයෙ open කරන්න madam. දැන් ඒක මොකක් කරේ ප්‍රශ්නයක් වෙනවා.
ප්‍රශ්න මම ඔයාලට මෙහෙම එව්වොත් can you put it to the screen? Then,
I have another meeting going on.
all right, that's fine. Because now I have opened it. Again, it says a problem with Zoom.
Okay, madam. Now it's opened up.
Right, okay. Right. Can I start it?
Yes, madam. Yes.
Right. Good morning. Sorry for that technical issue. At the outset, let me thank the College of Sri Lanka
Madam, you have to unmute.
Okay now?
Your presentation went off, madam.
Can you see now?
Not yet, madam.
Can't you see?
Can't see the presentation.
Can you now?
It's not opening up, madam.
As soon as this lecture shared, the Zoom quits unexpected.
Prashant, when we open these lectures, the Zoom quit unexpectedly. That message Can you see the screen?
Not yet, madam.
Hello.
Madam, madam, that's share card.
Are
The
you okay?
problem is when I share the screen, when I share the presentation, the Zoom quit unexpected. That's what the message comes here.
Madam, then share
Now I
card.
share, now I will share it. Now I share. Yeah, now I shared the screen. Now
Madam, share කරන්න කවුද? Madam මද නැත්නම් වෙන කවුරුද? Same computer or some other computer? Hello. Yeah.
can you share the screen?
Share करें.
Wait for me. Share screen. Send to him. We can speak to him. Madam, how making down. Making down. Let's have a lecture. Call
Madam, full screen කරන්න බෑ. නැත්නම් okay ඊළඟ slide එක click කරන්න madam. මාතලේ signal මතියද නේ. Madam, email කරනවද presentation එක? Right, I think there's a small technical issue with Dr. Tushari Manigaratna madam because she's joining from Matale. But we are going to the next lecture by Dr. KVC Janaka, consultant physician on dengue essentials. Over to you, sir.
Yeah, good morning. Let me start sharing. Can you see the slides? Can you see the slides? Hello?
Yes.
Hello?
Yes, sir.
You can see the slides, no? So
Yes, sir.
shall I start the
Yes. Please start, sir.
okay, right. Yeah, now I will try to this was the same lecture that I did for the previous batch as well. So this is regarding the dengue management for the interns. So actually what we really want is you to monitor the patient very well, then we'll make the management decisions. I'll go one by one. So what we know is that most of the dengue patients are asymptomatic, right? So they don't come to the hospital. And the incubation period is 4 to 5 days. Period is 4 to 7 days, and can even be up to over 2 weeks. So they can come with a fever, just a simple fever to the outpatient department, or dengue fever, or DHF, or expanded dengue syndrome, that is with complications. So it's the same thing that we say dengue viral infection. Most of them are asymptomatic. Then some of them are symptomatic. From this symptomatic group, some has just simple viral fever. You don't have to do anything. Just give paracetamol, bed rest, and normal hydration. Then you get dengue fever. That is the patients who are not leaking. You don't have a clinically significant leaking. That is dengue fever. DHF is a group of patients who shows clinically important leaking. And then the expanded dengue syndrome, where dengue DHF will go into develop shock and other complications, right? Expanded has a lot of other like various complications, maybe encephalitis, maybe liver failure, things like that. Right. Now, my main task is to teach you how to manage DF and DHF in the ward. When you take the illness, initial 3 days, usually just a fever only. So we call it a febrile period. Then you have 3 to 5 days or 3 to 6 days where the patient can leak. So that period is called critical period or a high risk period. Then from day 6 on, actually on the day 7, the patient start recovering. Patients start recovering, right? So the critical phase is the most important period. Here, the patient will show some evidence of plasma leakage. I'll tell you what are the evidence of plasma leakage. And it usually occurs at around day 6, day 3, and can go up to about day 6 or even up to the day 7. And it ends with the day 7. Right. Plasma leakage. This is important. So the exact pathology, why they leak through the capillaries or the small blood vessels. Actually, it's increased permeability of capillaries. The exact mechanism or the immunological mechanisms are not well known, but due to some reason, dengue patients start leaking fluid. So it's a transient thing. Usually it's in the critical phase from day 3 to day 6, and they have a spontaneous recovery of the leaking phase, right? And other interesting thing is this leaking is mainly into the peritoneal and pleural space. And sometimes there can be a small pericardial effusion, but they don't leak like now if you take nephrotic syndrome or if you take cirrhosis, they get fluid overloaded and their leakage, you see their fluid collected in the legs. They have generalized edema. But in dengue, this is a selective serosal leakage due to the serosa, that is peritoneum, the pleura, and the pericardium. And there is also some leaking into the tissues, which you don't see. But if you see a patient with dengue who has ankle edema or who has facial edema, or in other sense generalized edema, it is evidence of fluid overload. Now, when the plasma is this is a selective plasma leakage. When the plasma is leaked out, cells remain inside the blood vessel, so the hematocrit will increase. So rise in hematocrit or rise in hemoglobin, both are same. Either hematocrit or hemoglobin concentration will increase when the plasma is leaked out. So if it is more than 20% from the baseline, we take it as a very significant leakage, right? Then the other evidence are, you can see the leak through the ultrasound scan, especially around the gallbladder and around the kidney. And then the serum albumin will also drop, which is another evidence for albumin leak. And even the cholesterol will leak out. So if you do cholesterol or albumin, that those are also will be low, but we usually don't do this in dengue patients. In doubtful situation, someone, the consultant might decide to do this. Otherwise, routinely we don't do albumin or cholesterol. What we do is the hematocrit and the ultrasound scan. Now I'll give you some examples. Now take this the cylinder, which is centrifuge. You have in the top you have the plasma, and you have red cells. Usually red cells are about 40% of the volume. If you take the volume wise, right? It's about the 40%. Then in a normal person, 60% is plasma, 40% roughly. It depends on the hemoglobin, either 42, maybe 45. Some people maybe even up to 48, right? In females, sometimes when they are a little bit anemic, it can be even 35. So normally they are PCV or hematocrit is around 40. Now when they leak, what happens is the hematocrit or the red cell, the volume will remain same, but the plasma will go up. When you take the percentage wise, the hematocrit is increased. So when you do the capillary refilling, the capillary tube and centrifuge it, you see a rise in hematocrit, which is due to the leak out of plasma, and the patient will have some urine output. When the patient bleed, what happens? When the patient bleed, plasma will remain almost the same, but hematocrit will drop. So that is evidence of bleeding. So if somebody's hematocrit is dropping, we have to think of possible bleeding. If someone bleed and leak at the same time in equal amounts, the hematocrit may remain at the same level, right? So it varies. It depends on the amount of leaking and bleeding. So sometimes if the leaking is more and bleeding is less, you will see a rise in hematocrit, but it is not the expected rise. Or if the bleeding is more and the leaking is less, you will see a drop in hematocrit, but not the expected drop if it is pure bleeding. So bleeding and leaking will make it complicated, right? So you won't see sometimes. So if a patient bleed and leak at the same time, hemoglobin and the hematocrit or the PCV can remain same without a change. Right. We hydrate. If we give a lot of fluid, again, what will happen? Now, this is a situation where somebody is leaking. This is a common situation in the ward, and you are giving fluid. So when you give fluid and you balance the leak, what will happen? The hematocrit will not change. Now, patient is leaking, but we are giving fluid, so the leak is balanced. The hematocrit will not change. So patient is actually leaking, but we don't see it as a leaking through the hematocrit. You will see it through the ultrasound, but not by the hematocrit, right? Now, if we give a lot of fluid and patient is leaking, if you give too much fluid, more than what patient leaks, then you will see a drop in hematocrit, right? Then you will see a drop in hematocrit. It's not bleeding. It is just patient is leaking, but we are giving too much fluid. But then you will observe that the urine output is good. If it is bleeding, urine output will drop. But here, you are overhydrating, or more than the leaking, and patient is passing a lot of urine. Now we'll go to true scenarios. These are all true scenarios. Can you all switch off your cameras? Then it is easy because it will distract others, right? Can you all switch off your camera? Now we'll go to a true scenario. A 25-year-old man, you can always ask the questions after the presentation. A 25-year-old man on admission had fever for 5 days and he was feeling faintish. And his GCS was 15/50. Weight is 75 kilos. Blood pressure was 115/70. Heart rate 114. Respiratory rate 22. And we have no idea about the urine output on admission. Right? Now, how would you proceed? This is the real scenario you get when you are a house officer. Patient comes and tell you, I have fever. And you check the blood pressure, 115/70. Heart rate is high, tachycardic. And you have no clue about the urine output. So what would you do as the house officer? But what would you do? The examination? What is your management? Right. So what are the examination steps that you should do? Now in Sri Lanka, if somebody comes with fever, always you have to think of dengue, right? As one possible diagnosis. Always. Right. Whatever the history. Now these days we see some patients coming with severe sore throat, pustular tonsillitis, and dengue antigen also positive. Right? So you always think of dengue also. Right? Right. Sorry, now most important thing is liver tenderness. You examine the liver, see whether there is liver tenderness. You check for capillary refilling, right? The capillary refilling is, unless you are experienced, you might miss it, but you should do in every patient and then you will learn to do it. And liver tenderness, you have to check. So you do this, examine this patient, there was no liver tenderness, capillary refilling was good, but he has tachycardia, right? And then you do a bedside hematocrit, right? You do a bedside hematocrit. And it is, in this patient, it was 46. Now, except for tachycardia, this is a stable patient. Stable in the sense, there are no evidence of leaking. Liver tenderness is not there. Blood pressure is okay. You saw the pulse pressure, right? Pulse pressure is more than 45, right? So there is only tachycardia. In this type of patient is stable. So you have time to manage this patient. You understand? Now, he has tachycardia. You have to be careful. It can be doing many things, right? But that is the only worrying thing, tachycardia. Right. Another patient. A 36-year-old lady transferred from a peripheral. All these are real situations. Huh? 36-year-old lady transferred from a peripheral unit. She has a history of fever for 6 days. So if it is dengue, day 6. Right? And she has a menstrual bleeding for 1 day. And her platelet count was 85,000. Hematocrit was 40. hemoglobin was 11. And they have given saline and 1 liter of dextrose. I don't know why, but this was a real situation we experienced. I don't know whether they didn't have anything else, but they have given a saline. They have given 1 liter of dextrose. Maybe, I don't know whether their glucometer showed low. I don't know. But this was a real situation. This patient came to the hospital. Now, what are the things that you see here? Now we see a dengue patient who has given 1 liter of dextrose, which is not recommended in dengue fever. We always advise to replace the fluid loss something similar to plasma or equal to plasma or isotonic, right? So the isotonic is normal saline, not dextrose. Dextrose is equal to just giving water, right? However, you see that her hematocrit is 40, HB is 11. What does that mean? Nothing. What that mean is she may be having leaking, and we know that she has menstrual bleeding anyway. So her hemoglobin is normal. Maybe that she is leaking a lot, right? More than she is bleeding. Or maybe that she has not bled any significant amount, and she has not even leaked a significant amount. She may be a stable patient, right? We don't know. When you go through this thing, you don't know whether the patient is a stable patient because the PCV is normal, or whether the patient is leaking a lot and bleeding at the same time. This is what we have to think, right? So on admission, that is what, on admission, when you do the examination, her GCS was normal. She had PV bleeding. Her blood pressure was 90/70. Heart rate was 100. Respiratory rate was slightly high. And the hematocrit was 38. That is 40 at their hospital. Now it is 38. We have no clue about the urine output. Now, as house officer, you will receive this patient in your ward. Now, from your mind, think, what would you do? Or you can even type it as an answer. What would you do? I'm not going to do a verbal conversation here because we have a very high number. It will be a chaos. Anybody who wants to type the answer, you can type the answer. Right? So what are the things that you know? We know that this patient has probably dengue fever because the platelet count is low with the normal WBC count. And she probably has some amount of bleeding through the vaginal bleeding. She has a tachycardia of 100, slightly increased respiratory rate, and her blood pressure. Blood pressure is 90/70. What does that mean? Okay, blood pressure, the pulse pressure should be usually more than I just checking the messages. Nobody has answered the question. Right. The pulse pressure usually should be more than 30. Right? That is the rule. Pulse pressure should be more than 30. Blood pressure of systolic of 90 does not always indicate shock, because in young females, sometimes that may be the normal blood pressure, systolic of 90. But the pulse diastolic of 70 when the systolic of 90 is not normal. So that is a narrowing of pulse pressure. That's narrowed. So it is evidence of intravascular fluid depletion. When you lose intravascular volume, the systolic blood pressure, there will be vasoconstriction. So the body will try to maintain the systolic blood pressure, or it may even slightly go up. Right? But because of the vasoconstriction, diastolic pressure increases. Low volume, systolic will drop due to the volume loss. So body is trying to increase the heart rate, vasoconstriction, the systolic is going to drop due to the volume loss. Diastolic is going to go up due to the vasoconstriction. So drop in systolic, increase in diastolic, or maintaining the diastolic at the same time with vasoconstriction, the pulse pressure drops, right? So the pulse pressure is 20. So this is evidence of volume loss, intravascular volume loss, right? So there's intravascular volume loss, there's tachycardia, but hemoglobin is almost normal. So the patient has a lot of leaking. So when somebody is having leaking, what should happen to the hematocrit? If somebody is leaking, hematocrit should go up. Now this is her chart. She was initially started with 100 ml of saline by the house officer. Systolic was 90, diastolic was 70, pulse pressure was 20, heart rate 106, platelet was very low, the on-admission platelet was, respiratory rate, PCV, urine output was 10 ml per hour. Is that adequate? No. The expected urine output is at least 0.5 ml per kg of the body weight, right? So we take all patients in adults more than 50 kilograms. We take their body weight at 50 kilos, and she should have at least produced 25 ml per hour, but now she's producing only 10 ml. So whatever the amount of fluid we are giving is not adequate. She is not passing enough urine. She is in pre-shock, actually shock. Her pulse pressure is 20. Her heart rate is high. Now the next option is the house officer or the SHO gave a dextran of 250 ml, right? So what happened with that? Urine output increased slightly to 18, tachycardia remaining, pulse pressure improved slightly, but patient is not improving. Next hour, they gave 150 ml, urine output is still 15. This is a real chart, right? It's a real chart. Next hour also they gave 150 ml, urine output slightly improved 20, pulse pressure slightly improved 22. Now what are you going to do? Can someone write the answer at this stage at least? What is your answer? Yeah, some people are answering. Okay, good. Good. Good, lot of people are answering. Good. Yeah. Now this is a patient who has evidence of fluid volume loss. And if it is pure leaking, the hematocrit should be high, but her hematocrit is not high. So even if the hemoglobin is 11, this is a situation where you give blood, right? So in dengue, you can transfuse blood even when the hemoglobin is normal or the hematocrit is normal. You don't look at the full blood count and say, her hemoglobin is normal, she does not need blood. No. Her hemoglobin is normal because she has loss of fluid. There's vasoconstriction. Sorry, there's hemoconcentration. She has lost a lot of fluid. Her hemoglobin is normal because of the loss of fluid. Her ideal hemoglobin should be very high because of the leaking, but it's not going up because she's bleeding. So the treatment is blood. So those who answered as blood got the correct answer. The real situation, right? Right. Then another patient on admission day 5, faintishness, same scenario, but slightly different. GCS 15 by 50, blood pressure 100 by 70, heart rate 100. Now this patient, we know that pulse pressure is 30. 30 is not normal. It should be beyond 30, more than 30. So this is mild, just like impending shock, right? Respiratory 22. Urine output, we have no idea when they come into the hospital. You are the one who faces this, not us. When you see the patient is sitting in front of you, smiling, saying that I have fever for 5 days. You check the heart rate, is 104. You check the blood pressure, 100 by 70. So if you don't check the blood pressure correctly, you are going to totally miss the patient. So checking the blood pressure correctly, checking the heart rate correctly is very, very important. Right? You check the blood pressure, you check the heart rate. Then you have no idea about the urine output. You start monitoring the urine output. So again, now this patient has liver tenderness, right? So he is leaking. PC is 58, leaked a lot, right? He's almost going to die, right? Patient might be smiling at you, but this amount of leaking is very difficult to recover, right? It's very difficult to recover. Young people, they don't collapse until the end. They might come walk into the ward and they might be talking nicely, maybe joking with the family members. But if the PCV is 58, it is very severe leaking, right? Then you have to be very careful. You start a bolus. So any dengue patient, most important thing is, as soon as the patient comes to the ward, do a hematocrit in the ward, right? Bedside hematocrit. Especially if the patient has any evidence of any clinical evidence of DHF, like tachycardia, liver tenderness, faintishness, right? So any worrying sign, do a bedside hematocrit. Don't wait till the full blood count comes from the lab, right? It will take some time, because if when they send the full blood count, if that shows something abnormal, either low platelet or something, they might even repeat it. So they might even waste time on doing a manual count, right? So you will lose the time, crucial time. So this is the patient again. He was started on 100% saline. That is the usual practice by our doctors. As soon as they come, they put them on 100 ml saline and monitor the blood pressure. But you see, low urine output, every hour urine output is low. Now, if you don't palpate the liver and diagnose that liver tenderness and start hourly monitoring of the urine, or either you don't put the critical monitoring chart, you will not detect this patient at least till about 3-4 hours, right? So you have to be very vigilant. Do the blood pressure, do the pulse, look for the liver tenderness. If you suspect anything, start hourly monitoring. We can reverse back. You can do hourly monitoring. If the patient is stable, everything is normal. If the platelet and everything is normal, you can go back to a relaxed monitoring. But if you suspect anything worrying, start hourly monitoring as a DHF, right? Don't do the other way. No urine output, then what is the option? You give saline bolus and followed by dextran. This patient is very difficult to manage, right? This is another true story, right? This one I saw in a meeting, actually, not my patient. I saw this patient in a meeting. 3 or 5 days, I tell this story to every intern I meet with, right? And every registrar. 3 or 5 days, and he did not have a fever for 1 day. He had a very important cricket match in the school. This happened in a very dry zone, right? Dry area in the country. So he had to play a cricket match. He went and played the cricket match. So he was fever-free 1 day. So we know that whenever our children are fever-free, even by artificially with drugs. Parents want to send them to play the games and tuition class and things like that. So he wanted to play the cricket match. He went and he's a young boy. He is very fit. He played the cricket match from morning to evening. Then, and it is very hot weather, dry zone. Then he came to the doctor, actually came to the consultant in the evening, complaining faintishness and reduced urine output. To the private sector, right? Here the consultant checked the blood pressure, heart rate 90/70, heart rate 96. So he knew something is wrong. Either fever, history of fever 6 days, whether it's dengue, septic shock, no idea. He asked them to take the blood for dengue, full blood count, and asked to admit immediately to the hospital. Right? He should have put a saline there, but from the way the patient came, like nicely talking with the cricket suit, he didn't expect the private hospital, and the government hospital was very nearby. So he asked the child to go to the hospital. They came directly to the private government hospital. Right? This is a true story. On admission, this is from the BHT. GCS was 15/15, weight was 65. No history of melena. Blood pressure was 100/80. Heart rate was 90. Respiratory rate, usually we don't, most of them don't record it. Ideally, it should be recorded, but not recorded. Urine output, no, it was reduced, no idea. And no lab reports. So the house officer put the patient on normal saline 100 cc power and start dengue monitoring. So when you put dengue monitoring, nurses will start monitoring 3 hourly, right? 3 hourly blood pressure, pulse, urine output, same thing, right? But what was missed here, blood pressure was 100/80. So that is shock. The fact that he was in shock was missed, right? So at 7, blood pressure was 100/80, heart rate 94, respiratory rate 26. Urine output was 5 cc per hour, right? Because they got the lab report at 7 o'clock. Actually, you are fortunate if you can get the blood report in 2 hours, right? Most of the hospitals, you may not even get that, right? So we have to be very careful. Bigger hospital, usually labs give it, but sometimes it's difficult. Even in some private hospitals, you don't get it. Right? So he was fortunate to get that platelet counted, and it was, platelet was 34,000. Hemoglobin was 11.5, PCV was 40. Now again, this is a child, young boy who had played a cricket match, who is fit. Blood pressure 100/80, heart rate 90, reduced urine output, and low platelet count with normal hemoglobin, right? So what should have been the ideal management? Should have done a hematocrit on admission. Then again, hematocrit will come as 40. So then still there is a chance that he might think that is normal, right? It's normal. So ideal situation would be, if you suspect dengue and if you suspect shock, when especially blood pressure is low, if you look for liver tenderness, it should be there. Definitely it will have been there. Or if you have a bedside ultrasound, put the ultrasound on the abdomen and check for leaking. If they did it on admission, if they did the PCV on admission, if they detected the leaking, then they could interpret that leaking is there, right? But it didn't happen. I don't know. I think they didn't have, this is about maybe close to 10 years back, right? So probably they didn't have an ultrasound in the ward at that time. I don't know, right? So anyway, there was nothing about the liver tenderness mentioned. We know that. So this is at 7 o'clock. So this is the chart. Fluid was given at 100. At 7 p.m., they gave a 250 bolus. And look for increasing in urine output. Actually, it improved to 20. But pulse pressure remained 20, 25, 21, right? So they have increased the fluid again, 150. Then at 10 p.m., they gave 250 of dextran, right? Then the urine output improved 25. And again gave 150, again not much improvement. Repeat of dextran at 8. At 9 o'clock, they started blood, right? This is a real situation. Actually, this hospital didn't have a blood bank. So they ordered blood somewhere, I think around 8 o'clock in the night, right? Or maybe at 10, I don't know. And they got the blood a little bit late. Right? They took about 1.5 to 2 hours for them to receive the blood. Right? Because they had to come to Chilaw Hospital and get the blood and go back. Right? I was in Chilaw at that time. So they started blood transfusion at 9 o'clock. Right? So what do you think would have been the outcome? Anybody can guess? At 11 o'clock, they started the blood at 9:30 somewhere. At 11 o'clock, the boy started having hematemesis and melena. And by 12 o'clock, he died. Right? This is a boy who played a cricket match in the morning, played full day, came to hospital at 5 o'clock, and died at 12 o'clock, 12 midnight. Right? He was smiling, chatting. We played the cricket match and died at 12 midnight in the hospital after being 6 hours in the hospital. Right? So what can we do? It can happen to you, right? It can happen to you because you as a house officer will be seeing every day a lot of patients. You may be seeing 10, 15 dengue patients a day. You may be seeing a lot of fevers every day. So you would not, unless you are vigilant and check the pulse pressure, liver tenderness, tachycardia on admission. And if you don't act on that immediately, unless like if you see a patient, whether the platelet count is there or not, doesn't matter. If you see a patient where the pulse pressure is low, tachycardic, you have to suspect dengue shock. Look for liver tenderness. If you have the ultrasound, keep it on the abdomen and look for bleeding, look for fluid. If there's fluid that is leaking and your bedside hematocrit will show whether the patient is bleeding or leaking only. If it is leaking only, it will be very high. Bleeding and leaking, it will be normal or slightly low. If it is low, it's bleeding. So give blood as early as possible. So this child died because everybody missed to the house officer and the SHO and probably the consultant at the private sector didn't thought of bleeding at that time. Right? If they inform this to the consultant, they didn't thought of informing the consultant also till they started transfusing blood. So this is a real scenario. All these were real scenarios. So you have to be very vigilant during your internship. You should not kill anybody because of your negligence. That is what we want. We don't want you to make hi-fi diagnosis. We want you to be vigilant, see every patient, check their blood pressure, check their pulse pressure, look for liver tenderness, do bedside PCV, do the monitoring correctly. Rest you will learn automatically. Right? Another patient. On admission, actually, I was given a little bit more time for this lecture because of this importance of this dengue, right? Because we don't want anybody to die in our wards with dengue. Right? On admission, we were 7 days. So the patient should be recovering 7 days. ECG is normal. Blood pressure is normal. Pulse pressure is 50. Tachycardia. Why is that? Respiratory bilateral fluorescence, body swelling, ascites. So when you have a lot of fluid, it increases the tachycardia. There's a reflex tachycardia. We have no idea about the urine output on admission. You examine the patient again. PCV is 43, capillary refilling is normal. What is the fluid of choice? You don't start fluid immediately because the patient is overloaded. So you put the catheter, get the urine output and see how it is happening, right? If the patient is passing urine, patient is stable, just tachycardia only, you give some time, let the fluid go out. Right. Now, other thing I have to tell is, now we say you monitor hourly. If somebody is not producing enough, you put the catheter. If the patient is not producing enough urine, you don't have to wait 1 hour to make the decision. You wait 10-15 minutes and look at the back. If the patient is not producing enough urine within 10-15 minutes, you know waiting 1 hour will not add anything more. You can do the next thing in half an hour or 15. The bolus immediately, right? So what now? Other thing, the ward round, right? So what would you tell the consultant, or what would you check during your daily ward rounds, right? Daily ward rounds. Can we switch off the cameras again, please? Can everyone switch off your cameras, please? Right. What should you tell the consultant? Ward round. You should tell the consultant whether the patient has BF or DHF and how many days of illness. It is very important. If it is day 2, day 3, we know the patient is going to may leak in next few days. If it is day 7, we know patient is going to recover in next few hours. So it is very important. What is the last platelet count and the trend? Yeah, platelet count alone does not have any value. A patient with platelet count of 90,000 can bleed and leak and die. On the other hand, a patient of platelet count of 5,000 may not have bleeding or leaking or anything, right? So the platelet count does not matter. It is the trend. If the platelet is dropping, we know patient is progressing. The illness is progressing. That's all. Illness is progressing. If it is rising, we know that patient is recovering. That is the important, right? What is the trend of WBC? Again, it is important because with the platelet, WBC also will drop in the initial part of the illness. Then the WBC will go up. The initial rise of the WBC is the time where the patient is going to leak. Then after that, when the WBC is well up, like 5,000, 6,000, definitely patient is going to recover, right? So it is important. Trend is important. Then another very important thing, blood pressure. We saw how it is important. And the pulse pressure and the heart rate. These are very important, right? We are not very worried about the full blood count. We are worried about the day of the fever, blood pressure, and the heart rate. Things that I have put in red. Then the hematocrit. That is again very important. We saw during the cases, right? And liver tenderness, evidence of ultrasound, evidence of leaking, right? You have to tell in the water, but we can also palpate and see. And the urine output. We don't want the total urine output. I don't mind even if the patient doesn't pass urine 24 hours prior to the illness. I want to know what is happening with the patient now. If the patient is okay now, I am happy, right? So you have to tell me during the ward round, what was the last 2-3 hours urine output? That is the most important thing, right? Not the 24-hour totals. Because when you go to a surgical ward, they will take they talk about the 24-hour urine output. In medical wards, in dengue, we are worried about the last 2 hours. Right? It's a very dynamic illness. It changes very quickly. And if the patient is leaking, how many hours has passed? We know the leaking phase is about 48 hours. So we want to know how many hours remaining, right? How much, what is the current fluid rate? How much are we giving? How much fluid have we already used from our quota? Here I didn't talk about quota calculation, right? That's basic principles. I want to concentrate on the inward management. You calculate the quota according to the body weight, you know that. And then that is the end. I can answer any questions. Now you can switch on your cameras or mics and answer any questions. Ask any questions if you want. I hope it was clear. So all the house officers, all the doctors who are going to come as house officers should read the National Dengue Manual before coming to the wards. Right? It's a must. It's available in the internet. Okay. Shall I stop now? Somebody has asked what would have been the ideal management of that 17-year-old boy. Yeah, ideal management would have been, now when you check the blood pressure, it was low, pulse pressure was low. And we have a history of fever for 5 days, right? So then we have to suspect some form of shock. Patient is complaining. So ideal would have been to start monitoring hourly and check the urine output next hour, right? And the blood pressure. So if the patient is not, and you can definitely, you don't start blood on admission. You could have started the saline. Then because the patient is not improving within next hour, you can repeat the PCV. You could have done the PCV. Even if you missed that, when you got the full blood count at 7 o'clock, with low platelet, patient in shock, normal PCV, that is the time to get blood as early as possible and give blood as a bolus there, right? To give a bolus of blood fast. That would have been ideal. Right. Somebody has asked when to discharge patient. Okay. A good question, actually. So I didn't talk about that. Usually we discharge when the patient is clinically well, that is when they have improved their appetite, right? Their blood pressure is normal, heart rate is normal, pulse pressure is normal, fever free, and they have good appetite. And the platelet count is gone up at least in 2 counts, right? Morning and evening, if it is going up, because sometimes one platelet count can be wrong. So we have to make sure that it is a true rise in platelet count. So if the platelet count is going up in subsequent samples and the patient is in day 7 or 8 and appetite is good, because at the end of the illness, sometimes there can be problems, like you can't just decide only platelet count alone. Some people get cannula site infection, some get urine tract infection due to catheter, some get pneumonia. So there shouldn't be any other complication. right? Liver enzymes can be high in sometimes 300, 400. It is okay to discharge. It will come down. But patient should be fever-free, appetite improved, platelet should be rising, right? Then you can discharge the patient. Right. Shall I stop? Yeah, I think it's time to stop.
Thank you, sir.
Yeah, there was a question. I will answer that also.
Okay,
By
sir.
any chance, can patient have a reduced urine output with fluid overload? Yes, definitely. That is, if you give too much fluid in the beginning, and patients will have fluid leaked into the extravascular compartment when the patient is going into the shock. So it is a very difficult situation where patient has ascites, patient has pleural effusion, and patient is in shock because intravascular fluid loss or volume loss. It is a very difficult stage to manage. We manage them with very difficult. It is usually they have to be in the ICU like setup. You can manage in the ward. You have to be very careful, hourly monitoring, and adjust the fluid slowly. And there were situations where we had to put pleural. We had to drain the pleural fluid to give some fluid because the pleural compartment was full. Sometimes there were a lot of ascites compressing the IVC, right? And the intravascular volume was low. So this is a very difficult. You manage them with dextran and blood and things like that as much as possible without giving minimal of fluid. It is a difficult situation. It can happen. Somebody has asked whether we can give norethistone. Definitely. When there's PV bleeding, you can give norethistone, no issue. But it will just prevent the PV bleeding. You will need actually most of the females with dengue, they will have menstrual bleeding, not prior to their expected date when they get dengue. So we frequently use norethistone. Okay, I'll stop there. Thank you.
The next session will be conducted by Dr. Dilusha Surya, consultant physician. Over to you, madam.
Okay, thank you very much. Let me just share the presentation first. Are you able to see the slides?
Yes, madam. Yes.
Okay. Right. Good afternoon, everyone. I'm Dr. Dilusha Surya, and I'll take you through as an intern what you need to know about how to approach a patient with chest pain. So this is a very common topic, and as interns working in medical wards, it's almost certain that you will see about at least 5-6 patients a day at least coming with chest pain. So it's one of the most common presentations that you will encounter. So it's something that you really need to know well and know about and be thorough with, because it has a varied list of differentials, very different causes. And some of these causes could be very minor ailments, which you don't really need to worry much about and just need some analgesia. But some of the causes are life-threatening causes. So that is why it is so important that you know how to analyze a chest pain, how to come to a diagnosis, and what immediate actions you should take as an intern, because you're going to be the first contact doctor for these patients. So like I mentioned, there are so many causes of chest pain. And any organ in the precordium can give rise to chest pain. So coming from the heart, the sternum, the ribs, the joints in the precordium, then the lungs, the pleura, the pericardium, and even organs in the epigastric area. They can get radiation of the pain, the subdiaphragmatic organs, and that can present as chest pain. So there is like an exhaustive list of causes. But from all these causes, like I mentioned before, there are some life-threatening causes, and those causes should always be in the back of your mind. When you're clerking a patient with chest pain, always think, am I missing any of these main life-threatening causes? So you can use the 4-2-1 rule to remember these life-threatening causes. There are 4 that come from the heart, 2 that come from the lung, and 1 that comes from the mediastinum, really. So the 4 that come from the heart are acute coronary syndrome. You know what falls under acute coronary syndrome, that is acute ST elevation MI, non-ST elevation MI, or unstable angina. Then the second cause coming from the heart is aortic dissection, where you get dissection of the ascending aorta or the second part of the aorta, and then the descending aorta in the thoracic, within the thoracic cavity. Any of those parts can dissect, giving rise to chest pain. Then pericarditis and myocarditis, again, can be life-threatening because they can lead to a pericardial effusion, causing tamponade. So those are the 4 life-threatening causes coming from the heart. Then from the lung, you can get a pulmonary embolism or a pneumothorax, which can transform into a tension pneumothorax. And the one other cause is the esophageal perforation, because that can lead to mediastinitis and severe sepsis and can lead to rapid deterioration of the patient. So for these, all of these life-threatening causes, we have to identify them early through the good history examination and order the appropriate investigations, because I'll explain later, if you mistake one for the other, in fact, you might make the situation worse. So how do you sort through this exhaustive list of differentials and decide on what is the most likely cause for the chest pain in your patient? And that is through unfortunately, there is no shortcuts. You have to do a good clinical assessment of the patient, as with anything in medicine. So if the patient looks unwell, if the notes from the MOPD says C-stat because the blood pressure is low, or they have put a pulse rate that's high, or the patient when is coming in with oxygen, or the patient just looks generally unwell to you, you would start with the ABCDE approach, which you probably have already quite thorough with. But if the patient looks stable and his vital parameters recorded by the MOPD or the nurse who is admitting the patient to your ward looks all right, you can go through a more comprehensive history and examination. So in your history, as with any history of analyzing pain, you know there's a standard set of questions that you have to ask, because each of these answers to each of these questions will help you decide and help you prioritize your differentials. So the site, the nature of the pain, whether it radiates, how long it's been, the onset, whether it's sudden, insidious, subacute, how severe it is. You can ask the patient to rate it out of 10, 1 being 0 being no pain and 10 being the severest pain he can imagine. You can ask him to rate it, or even by looking at the patient, you will realize it. And then whether there have been any precipitant or relieving factors and any associated features like autonomic features. So while going through the history of chest pain, something I always ask a patient when I'm asking them about chest pain is to show me where the chest pain is. So the way they show the pain also, you can get some information, because quite often in cardiac ischemia, the pain is diffuse and they find it hard to localize. So they use the palm of their hand and put it over their chest and say that they feel like a tightening or a pressure. They may not even say it's pain. They may describe it as a pressure or a tightening sensation, and they can't localize it. They show it with the palm of their hand. But if they say the pain is like they take a finger and point it out to some point in the chest, that makes cardiac ischemia less likely, because it's a very localized pain that they are trying to say that they're having. So apart from asking the patient, you can these questions, you can ask them to show you where the pain is, and you can get some information from that as well. So when you analyze the answers to these questions about the site and the nature and all of that, you can grade the probability of this pain being due to a cardiac ischemic pain. I'll talk about ischemic pain first and move on to the other causes later on. So by analyzing how he describes the pain, so if they say it's central and it's a kind of a pressure, squeezing, gripping, are the words, heaviness, tightness are the things that they might use, and it's retrosternal, and it's related to exertion or a stress. Stress can be physical stress or even an emotional stress. And that they have been sweating, it's been radiating to the neck or the arm, that all of that makes the probability of ischemia, cardiac ischemia, quite high. So when you move towards the right-hand side where the pain is right-sided, or they describe it as stabbing, tearing, those are more sharp pains rather than diffuse pains. And they are either the increases with respiration or increases with position. All those make obviously cardiac ischemia less likely. So getting a good chest pain history is important, because it's you can narrow down your differentials. But remember that these are all typical features, and not all of our patients are typical. And some may present with cardiac ischemia, but quite atypically. Females quite often have trouble describing pain in this typical fashion. And the elderly also may not have pain, or may present even with confusion, because while they're having an acute myocardial infarction. One, because they may be having a cognitive impairment, or two, they have autonomic dysfunction, their pain sensation may not be the same, so they may present atypically. Then things like inferior MIs and posterior MIs give rise to pain in different areas that are not typical. So inferior MI can present with epigastric pain, and is quite often confused with GORD or gastric ulcer. And posterior MI can present with back pain. And also, you know that diabetics quite often have silent myocardial infarctions because of their autonomic dysfunction. So all of the features I described earlier fit into the typical ischemic chest pain, but remember, not all patients will fit into this. So the physical examination is quite usually normal in cardiac ischemia, unless any complications have set in. So when you go on to, after taking the history, when you move on to examining the patient, usually the physical examination findings are normal. Unless like the patient has developed pulmonary edema, then you might hear lung crepitations, or if the patient has developed acute mitral regurgitation due to the infarction or a VSD, then you might pick up a murmur. But other than that, and the blood pressure may be high or low if the patient is in cardiogenic shock. But usually the physical examination in cardiac ischemia will be normal. So the moving on to other causes of chest pain. So the pain in pericarditis is a much sharper pain, and typically the patient will describe it as radiating to the back, and it gets relieved by bending forward, and increases with respiration. And usually there is a preceding history. The patient may have had a myocardial infarction maybe a week or two ago, and they are coming with what we call Dressler syndrome. Or the pericarditis may be associated with a fever, like a viral pericarditis. So there's usually an associated history. This is not the only symptom the patient will have. And then when you examine the patient, you could feel and hear a pleural pericardial rub, maybe. So the pericarditis pain is quite different. So the pain in aortic dissection is very sudden onset, and it's a very sharp and tearing, unbearable pain. Patient is in severe pain, and typically it radiates to the back. And here there can be definite physical signs, where if the dissection is quite proximal, you can feel a radial delay or a radiofemoral delay when you're checking the pulse. So it's good practice, always quickly check the both pulse in both hands and the one radiofemoral, have a quick check to make sure the pulses are felt equally. And then there will be, because of that, a difference in the blood pressure in the arms. And if it's a proximal dissection, it may involve the aortic valve, and you can hear the early diastolic murmur of aortic regurgitation. And if it's gone on to involve the carotid arteries, there may be neurological signs also. Patient may be getting a stroke at the same time. So the aortic dissection, it's a sharper pain, very sudden onset, radius to the back, and very severe, unbearable kind of pain. So the lung also can give rise to various chest pains, and in pneumonia, when there's a consolidation, you can get a pleuritic type of chest pain. There the patient describes the pain to be more lateral, and it will increase with the respiratory inspiration and expiration. And of course, there will be associated fever, cough, and other symptoms. And the physical examination obviously will be abnormal as well. You will be hearing crepitations, bronchial breathing, and there will be definite positive physical signs. So pulmonary embolism, the patient will be short of breath. He'll be hypoxic. There will be pleuritic type chest pain and may even have hemoptysis. And in this case, however, the lung signs are usually absent, but the patient is markedly dyspneic and will be hypoxic. So if a patient is dyspneic, hypoxic with the absence of lung signs and is having pleuritic type of chest pain, PE should come up very high on your list. That's the first thing you need to exclude. While a pneumothorax, in contrast, again, it will have pleuritic type chest pain. Patient will be dyspneic, he might be hypoxic, but you will have a set of physical signs, that is reduced air entry and hyperresonance percussion note, hyperresonance, the phlebitis will be reduced and there'll be hyperresonant percussion note, and the air entry would be reduced. So all of that, those physical signs will be there. While in a pulmonary embolism, there won't be any physical signs, usually. Then the esophageal rupture or a esophageal spasm can very closely mimic a ischemic type chest pain because it's also retrosternally placed. And it can also be described as tightening and a pressure. And the pain can be quite severe, even with a spasm. But sometimes, the rupture can occur following a procedure. So the patient may have a history of having an endoscopy recently, or he has had a violent bout of repeated vomiting, or one vomit which has been quite violent, or repeated retching. So that kind of history may be there in this patient, but it is maybe difficult to differentiate. So as I mentioned before, you can get the pain due to the soft tissues, the skin. You can get pain because of herpes zoster in a dermatomal, in the thoracic dermatomes. It could be a musculoskeletal pain or referred pain from the upper abdominal organs, the stomach, the pancreas, the gallbladder, and the subdiaphragmatic space. So if there's a collection or something, you can get pain, referred pain. So now you've done your clinical assessment, you've done a good history, you've examined the patient, and you have some idea now what this chest pain is due to. But regardless of, so then we had to proceed on to investigations to confirm our diagnosis. But regardless of what pain it was, how it sounded, whether it was typical or atypical, whether it's a pleuritic pain or a very cardiac sounding pain or a pneumonia type of pain, I would recommend that in all your patients that you get an ECG. This is because, like I mentioned, patients can present in a very atypical manner. And this is one first thing, very easy thing to do. It's easily available. And it helps us a lot because it can rule in and rule out diagnosis in the matter of seconds. So in all your patients who you clerk with a chest pain, get a ECG done, and this ECG should be done within 10 minutes. If the patient is having quite severe pain, you might get your nurse or another colleague to do the ECG while you're examining and asking questions from the patient. So it is something that you can't leave like a half an hour or hour after seeing the patient. This should be done within 10 minutes. And not only should it be done, you should see it within 10 minutes as well. You can't just see the patient and ask the nurse to do ECG or call the technician to do ECG and go away and see another patient. And that ECG is left on the table or it's left in the notes. And you come back an hour later, see it, and you find that it shows a STEMI. So there's no point doing it quickly if you haven't seen it. So within the 10 minutes of assessing the patient, get the ECG and see it. But remember, doing one ECG may not be enough. You do it and it's normal and you can't leave it at that and be happy, because about half of the acute coronary syndromes, the initial ECG may be even normal. So always repeat. If the history is suggestive, or even if the history is not suggestive, patient is ill, always repeat the ECG, maybe in 20 minutes time or 10 or 15 minutes time, to see if there is any progression of the ECG or any dynamic changes. If the initial ECG is abnormal, it's always good to, especially if the patient has a previous cardiac history, it's good to try and find old ECGs to help with the interpretation, to see if there are any new changes. If there aren't any old ECGs available, try and trace the old records and see what people have written. Like they usually, if there's been an LBB, there's usually written in the clinic notes or the diagnosis cards. So equally, it is important as interns, when you're discharging patients and writing diagnosis cards, always write the ECG findings in the card, because the ECG tracings get erased with time. So even if the patient has ECGs from 2-3 years ago, sometimes it's all very faded and we won't be able to see it. But if it's written in the diagnosis card or notes, then it's very easy for us. We know that whether this is an old change or a new change. So make it a point. If it's normal, just make a note in the diagnosis card, ECG normal. Or if there's an abnormality, please record what the abnormality was. So the first investigation definitely should be a ECG. You do it quickly, you see it, even if it's normal, in 20 minutes, 15 to 20 minutes time, do another one, make sure it remains that way. So you've had a lecture on ECG, so I won't go into much detail. Obviously, acute coronary syndromes, ECG is very helpful in the diagnosis, but not only in that, because in pulmonary embolus, there are changes on the ECG, the commonest being a sinus tachycardia, but there are more other changes as well. And then in pericarditis, also you can see some specific changes. I won't go into much detail here because you've had a ECG lecture. So after the ECG, then you will think of doing the cardiac biomarkers, which are the troponin I and troponin, the high sensitive troponins, right? So you do this if you think the chest pain is suggestive of a cardiac ischemia. If it's an obvious ST elevation MI, there is no point in doing the troponin. But if it is a ischemic changes, you want to see whether this is unstable angina or NSTEMI. But if the troponin theta is very high, it's important for risk stratification. If it's a rising theta, again, important for risk stratification in terms of you can decide whether the patient can be referred early for revascularization and things like that. So the troponin is useful that way. But remember, positive troponin does not equal acute coronary syndrome. There are a whole lot of other causes, because you can get it's a reflection of myocardial ischemia, but you can get myocardial ischemia due to actual blockage of the coronaries, but you can get it due to other reasons as well. So type 2 MIs, where there is a mismatch. It doesn't meet the demand. The delivery of oxygen to the cardiac muscle is not meeting the demand of the muscle. Again, you will get a troponin rise. You can get a troponin rise due to damage of the cardiac muscle, like in myocarditis, or even blunt trauma and cardiac contusions. So there's a whole heap of causes, as you can see here, for a elevated troponin. So doing a positive troponin does not equal acute coronary syndrome. You have to analyze the patient as a whole. So know when to do the troponin also. You have to adequately time it, because if you've done it within like an hour of the patient having the maximum chest pain and it's negative, that will be a wrong interpretation, because it takes generally 3 hours to start rising. So when you go and start working in the hospitals, you ask, so different hospitals use different troponin assays, and because of the sensitivity, the time it starts rising can change from lab to lab. So know in the particular troponin, what is the expected time to start rising. So then you interpret it in the correct way. So always do the time troponin, making sure you're taking it at the correct time. And you can always repeat it to see if there is a rising titer. And remember that it can remain in the blood for 7 to 10 days, even up to 2 weeks. So it can, if the patient has had an NSTEMI recently and comes back 2 weeks later, troponin is still positive, it could be due to the old event. So a chest X-ray is also another useful investigation to rule out things. So in the case of acute coronary syndrome, you can use it to diagnose complications like pulmonary edema. But really it is for the other causes of chest pain. And I thought this is interesting. They say that in about 90% of the patients with a dissection, aortic dissection, there will be some kind of chest X-ray abnormality. So that's quite a high number of patients. So that will be quite useful. So you could see in the case of aortic dissection, there will be a widened mediastinum. And they say that now the aortic knuckle will be lost. Usually it's a very nicely rounded area here. So there's a loss of contour of the knuckle. The mediastinum gets widened and the heart looks globular. So there will be some kind of change in most patients with the dissection. So a chest X-ray is very useful that way. And obviously it's useful to diagnose other causes of chest pain. So here you can see a large pericardial effusion, large heart, globular shaped heart. So pericarditis, if the patient came with pain, it could be that. Then here there's a pneumothorax. You can see reduced lung markings and a collapsed lung. Another pneumothorax here where you see the line of the lung marking here. And remember I talked about referred pain. So we're doing a chest X-ray, you might see air under the diaphragm. And then you know the pain is actually the source is intra-abdominal. And in a case of a esophageal rupture, you will see some air along in the mediastinum, on the sides of the esophagus. So that's a feature of, and you might see a widened mediastinum as well. So the chest X-ray is also a very important thing to look for complications of acute coronary syndrome and to rule in or rule out other diagnoses. Then another test that's quite often we talk about in conjunction with chest pain is D-dimers, and that's another test that's quite misused as well. So D-dimers, is a test that we use in relation to investigating pulmonary embolism. But we have to know how to use it. We should not be ordering it in every patient. So the D-dimers have a high sensitivity to detect pulmonary embolism. So that means it's a good test to rule out. So if a patient, what we do is a patient comes with chest pain and we are thinking this pain could be due to pulmonary embolism, we have to do some kind of risk scoring, a risk score to see at how likely the patient is to be having a PE. So some of these are the names of some of the risk scores that you can use. Wells is something that we use commonly. So once you do the risk score, then it gives us a probability of the patient having a pulmonary embolism. So if the patient is having a low chance of having a PE, only low or intermediate chance, only we do a D-dimer. So then when the D-dimer comes back as negative, we can say for definitely, because it's got such high sensitivity, we can definitely say this patient is not having a PE. But if it comes positive, we can't confirm a PE, because as with troponin, you can see here, there's an extensive list of causes for elevated D-dimer. So the definitive test to diagnose, if the D-dimer comes positive in a patient with low probability of having a PE, you will have to do a CTPA or a VQ scan to diagnose the PE. But if you do the risk stratification and the probability of the patient having a PE is high, you would then straight away go and do the CTPA. So the D-dimers are useful, but they should be used in the correct context. So other investigations that you will do is obviously a full blood count to look for if there's an inflammatory cause. Then anemia, you have to look at the hemoglobin to see if the patient is anemic, because even if he's having ischemic type pain, ECG is showing dynamic changes, and the troponin is also high, but his hemoglobin is 5, you would not be treating this patient with dual antiplatelets and enoxaparin. You will be treating him with a blood transfusion, because this is all in keeping with the type 2 MI. So the full blood count is extremely important. And remember to look at the WBC and the hemoglobin as well. And the other useful investigations are the arterial blood gas. You can do a serum amylase and the liver functions, because pancreatitis, cholecystitis could also present with chest pain if the history is suggestive. So let me finish by going through 3 case histories. So this is, I would like you all to put the answers in the chat box if you can. So this is a 55-year-old man. He presents to the medical casualty with severe central chest pain, and that's tightening in nature, and it started 1 hour ago. He's sweating profusely, and on examination, his heart rate is 92 beats per minute, and blood pressure is 110/70. His lungs are clear and saturation is normal on UMEA. So going through this history, what is the most likely cause for his chest pain, you think? So as you can see, yes, acute coronary syndrome, because the nature of the pain, his examination is really normal. ACS is the most likely thing. So you're a good intern, you arrange a ECG within a minute of you seeing the patient. And this is the ECG. So what can you see on this ECG? Would you like to put the answer on your chat box? Yes, it's a ST elevation MI, but can you be a bit more specific? So it is involving, yes. So it's involving, it's an extensive anterolateral, isn't it? It's involved from V1 to V6. You are seeing ST elevations. So now you've taken the history from the end of the history and examination, the diagnosis of ACS is quite high on the list. You've done the ECG, and it is also more or less confirming your diagnosis. So from this point, you would act very quickly, inform your seniors, and because this is an absolute emergency, because time is muscle. And I would not talk about extensively about management of STEMI, But the immediate things, priorities, inform your senior, get him into HDU bed, give him pain relief, load him with the antiplatelets. Clinically, before that, assess whether he's pale or not, whether there's been any history of bleeding. Quickly, you can ask. Give him the dual antiplatelets, and then see if a primary PCI is possible or not. If it is possible, you have to arrange it within your institute or get him transferred within a reasonable period of time to another institute. If it's not possible, then you will have to go ahead and thrombolize the patient, right? So if you didn't do the ECG in time, within those 5 minutes, all of this will get delayed, and time is muscle, and the patient will be left with more infarcted muscle than if you acted quicker and everything was done in a timely fashion. So getting the ECG on time is crucial. So case number 2. So this is a 32-year-old man who comes to the medical casualty with burning type epigastric pain for 1 hour. He's only 32. He has been drinking with his friends the night before, and the pain came on few hours afterwards. On examination, he's sweaty, his heart rate is 92, blood pressure is all right. It's equal in both arms, his lungs are clear, saturation is okay. So from this case history and examination, what is the likely causes? So pancreatitis is one. Anything else? So it could also be kind of gastroesophageal reflux disease. It could be peptic ulcer. Yes. So the intern, he sends the bloods thinking all of this. He sends the bloods for full blood count and amylase, liver functions. He starts up IV PPI infusion, IV PPI and antiemetics, and takes a chest X-ray also. But he's forgotten to do the ECG. And when he does the ECG, when maybe the SHO or the consultant comes and says do ECG, this is what the ECG is. It shows an inferior ST elevation MI. So that's why I said, even if the pain doesn't sound ischemic at all, some patients present atypically and some diseases present atypically. So always we have to exclude the life-threatening causes, the treatable causes, early and in timely fashion. So in the end, he turned out to have an inferior STEMI. So we have to, and we probably miss the window of treating the patient if the ECG was not done in time. So the third case is a 75-year-old man. He comes with severe central chest pain for 1 hour. He's sweaty. His heart rate is 92. Blood pressure is 120 in one arm and 100 in the other arm. His lungs are clear. Saturation is all right. And you arrange a ECG thinking, okay, this is acute coronary event and this is what you see. So what is seen in this ECG? So what can you see on the ECG? There is a ST elevation MI, isn't it? In the inferior, it's an inferior ST elevation MI because there are ST elevations in 2-3 ABF. But somebody's already picked up this point. He is having a blood pressure difference in the arms. So even if he's having this ST elevation MI, we have to think, is there something else going on? Because if you give this patient antiplatelets or if you thrombolize him, you're going to, if there is a dissection, you can make things worse. So in any, so then you would think because of this blood pressure difference or the pulse difference, that some alarm bells should go off. Maybe you will do a chest X-ray then before you do the standard ACS treatment to see if there is any widening of the mediastinum. If you have a cardiology unit available, you might arrange an urgent bedside echo before you go ahead and treat him for ACS, because the treatment for ACS is quite detrimental if the patient is having aortic dissection. So though it is rare and though it's not common, we have to keep it in the back of our mind to see if make sure we are not missing it. So the final case is a 45-year-old patient He complains of severe throbbing pain in the right side of his chest for 4 hours. His vitals are stable. His examination, you examine his lungs, they are clear, but the patient continues to be in severe pain. You have arranged urgent ECG, and that also looks normal. But when you examine him carefully, you will see this, which is a rash. So if you listen to the lungs over the patient's clothes, you will not have seen this. He is having a herpes zoster rash, which can cause severe pain. So examine your patients carefully and never listen to a chest over the clothes. Always lift up, expose, because you will see things, pick up these things at the same time. So you wouldn't have missed the diagnosis if you examined him properly. Okay, so with that, let me finish by giving you the summarizing. Sorry, I'm just trying to get this to move. Remember, so that your role as an intern in a patient coming to the hospital with chest pain is absolutely crucial, because you're the person who will see the patient first, and your actions and you working in a timely fashion will make a massive difference to the care of the patient. So you play a very important role. And always keep the life-threatening causes in mind. When you're assisting the patient, make sure you are excluded them. There is no shortcuts. You have to do a quick but comprehensive evaluation to come to the correct diagnosis. Make sure any chest pain, you do a ECG within 10 minutes and that you see it as well. And if you have any doubt regarding the ECG, if you think that pain is atypical, if you have a doubt something else is going on, involve your seniors early and get an opinion from them as well. So I will finish there. Thank you. Are there any questions? I don't know if we have time. Can I answer any questions if there are any?
Is it okay for you to discuss a pericarditis case with an ECG when you have a slide?
Sorry, not very clear.
Acute pericarditis, madam?
Yes.
Right. Can you discuss a case with an ECG if you have? That is also.
Do you mean the changes in the ECG with pericarditis? Is it?
Yeah. Yeah. Not exactly what we find in the books, but what we usually get in the wards, madam, so that.
Yeah. So with pericarditis, it's a very sharp pain. The patient, the change in the pain with positioning is quite common, and that the patient may come out with, but you will have to directly ask that. And if that is there, it's very commonly there. Pleural rub, feeling it and hearing it may not, you may not be able to pick up quite often. But when you do the ECG, the classical things are there can be ST elevations, but they're saddle-shaped. They're saddle-shaped ST elevations, and they're widespread. So they don't really fit into any kind of territory like anterolateral or inferior or high lateral. They are widespread. They involve all the leads, chest leads, limb leads, widespread saddle-shaped ST elevations. And you can have PR segment depression, which they say is quite specific. The PR segment can be depressed. So troponins can be high. The inflammatory markers will be high. ESR, CRP, because it's an inflammatory process. The ESR, CRP will be elevated. WBC will also may be elevated. And then when you do the echo, you might see a pericardial effusion associated.
Thank you.
Any other questions?
Do you mind sharing your slides with us, please? Okay.
Okay.
Thank you.
Okay, then thank you very much, and good luck with your internship. Thank you.
Thank you very much, madam. Next, I would like to invite Dr. Prasad Sirivardhan to do the lecture on high and low CBS, how to tackle. Dr. Prasad Sirivardhan, are you there?
Hello? Can you hear me now?
Yes, sir.
Yeah. Hello? Hello? Hello?
Yes, sir. We can hear you.
Okay, so we start inpatient management diabetes mellitus. So we'll go through some few examples, the things that we can see commonly in the ward. Case number 1 is 20-year-old patient who has an insulin percentage, shortness of breathing. He comes with cough, fever, loss of 4 days. And the question he admitted he didn't take insulin for 2 days due to illness. He was febrile, dehydrated, and acidotic breathing. Investigation ketone body CB is high, index W is 15,000, CRP 215. What's his diagnosis? Okay, we are dealing with ketoacidosis. Ketoacidosis is a life-threatening condition, and so we have to treat patient very aggressively. There are some few basic principles are involved, and the thing is, first we have to hydrate the patient with correct liquid management, control acidosis, sugar management, DVT prevention, infection control, patient education, discharge. Those are the key priorities involved in this patient management. First thing is restore the volume and clearance of ketones and correction electrolytes. So these are the main things involved. So this patient have a major fluid deficit. It's somewhere around 100 meter kilogram body weight, and sodium deficit 10 to 10 millimoles per kilogram, chloride 3 to 5 millimoles per kilogram, potassium 3 to 5 millimoles per kilogram. So this has to be replaced gradually and steadily. So then sufficient ketosis, reduction glucose, and correction electrolyte. So, and we are giving patient this aggressive fluid, and we are giving it sodium chloride. So some example is given in this picture. But this fluid replacement depends on the patient condition. Supposing what's the patient volume status, blood pressure low, or if the patient elderly patient or heart failure patient, we can't give this much of fluid. So it should be tailor-made and should be given accordingly. And the ketosis patient, next important thing is giving insulin. Insulin earlier it was given as a sliding scale, and depending on the sugar level, we were titrating insulin up and down. But now it is different, and we are giving insulin as a fixed dose, and it is calculated on 0.1 unit per kilogram body weight, and its usually weight is just estimated. So given as a fixed dose infusion and with hourly monitoring of the sugar. And this dose, again, we are now not giving a bolus doses. Early we used to give some bolus IV dose to thinking to replenish the receptors. But the bolus dose is not given because it has a very high risk of getting hypoglycemia and further complication. So again, we are correcting all these elements very gradually. We need a reduction of ketone, 0.5 millimoles per hour. The problem is in our lab, we can check the serum ketone levels, so that we can difficult to do that. And increase in the bicarbonate by 3 millimoles per hour, and reduction of capillary blood sugar by 3 millimoles per hour. And one second, give me a call. Sorry for disturbance. Hello? Next thing is maintain potassium between 4 to 5.5 level. So these are priorities in management of ketone resources, and it should be managed very aggressively. Second example is a diabetic patient who's drowsy with a high index of sugar, and here we are dealing hyposomnia hyperglycemic state, and patient drowsy only, but not coma, but patient can go into coma. In this patients, it's a medical emergency again, and this patient different approach. But problem is, this kind of patient, they come to ward to the EETU, they are started on saline from one hand, and other hand they are started insulin infusion then and there. But this is not the case. These patients are living with the hyperglycemia for a long time. So they are they used to hyperglycemia and high osmolality. And so these patients are extremely dehydrated. So in the so again, this patient severe hypovolemia, mission osmolality is high more than 200, hyperglycemia. They run significant ketonuria, and pH should be normal low, not low. So these are markers to say the patient's severity. So management principles are, first thing is we have to normalize the osmolality and replace fluid electrolyte and normalize the glucose. And actually glucose coming in the third. First priorities are normalize osmolality, replace fluid and electrolyte are the number one priorities in this patient. That's how this condition different from the ketone resources management. Other thing is this patient is very prone to get arterial venous thrombosis. So if you aggressively correct the sugar level, they can get cerebral edema, centropontine myelinosis, or osmotic demyelination syndrome. So they can get, sometimes they can get a cardiovascular collapse if aggressively reduce the sugar levels. Therefore, insulin should not be started then and there. So we are not in hurry to start insulin as in the ketoacidosis. First thing is a fluid. So we have to hydrate the patient well with the normal saline and monitor the sugar level early. We can give fluid 3 to 4 hours gradually, monitoring sugar level. With sugar level, fluid only, they tend to settle the sugar level just with only a normal saline. And after giving enough fluid only, we are going to start insulin. And we are starting insulin very low dose. Again, giving fixed dose infusion is a 0.5 unit per kilogram body weight. We are starting this after correction of fluid deficit. And we want to reduce the glucose at the rate of 5 millimoles per hour. That's the ideal amount. Because these people are insulin sensitive, so sometimes they can abruptly reduce the glucose level. Therefore, we have to be very careful, and we need a very gradual and steady reduction of glucose. So these people can have hypo or hyperkalemia, and those has to be detected and corrected. Potassium correction is as normal in the ketoacidosis. Here the same. If the potassium level is comes below in the range of 3.5 to 5.5, we are giving 50 millimoles per liter, and below 3.5 means we need to give further more. So just to get an idea, and what's the amount of fluid deficit in this patient? In the 60 kilogram person, they can have 6 to 13 liter fluid deficit. So we are trying to replace with saline and gradually this deficit. Sexual reproductive current. As it is, we have to get the chair and taka. Okay, no body will have to lecture. And we can give some 9% sodium chloride 1 liter over 1 hour. And if the blood pressure less than 90, and we can go for rapid correction. And we are very careful in elderly. And elderly, if you give food too fast, they can present heart failure. And same time, we have to look for acute kidney injury also, and very common due to pre-renal failure. And these people, patient can got into a hyposmosis state due to sepsis, and it's a very ill patient. Therefore, we can take urine culture, blood culture, get a catheter in, and then can start empirical antibiotic like cephalosporin till you get the results. And same time, you have to check for X-ray and check for possible source of infection. And these people are very high risk of getting deep vein thrombosis and pulmonary embolism. Therefore, this patient needs a submodal low molecular heparin as a prophylactic doses. Case number 3 is a patient diabetes mellitus admitted high fever, CVS 340, and chest X-ray shows right low pneumonia, CRP very high, WC high. How is manage this hyperglycemia? Oral low medicine insulin, and also plan to discharge. Okay, this patient, severe septic patient, and with a pneumonia. This kind of patient, we are not giving oral hyperglycemic drugs. Even their sugar is under control, we have to convert them into the insulin. We are giving insulin, we are giving basal bolus regime. So this is our target in non-ICU patient. Pre-meal, we have tried to maintain less than 140, post-meal less than 180. So we are not going to go very, very low level like that, less than 100, and it tend to show increased mortality. In ICU setting also, lowest we are maintaining 10 to 140. If the sugar level is 180 only, we are starting insulin. And so I have seen most of these kind of acute ill patients, they are given continuous insulin infusion, and it's common practice with hourly sugar checking with increasing up and down the insulin levels. That is not recommended, and it's with the all patient one. And only basal bolus regime is recommended. Basal bolus is we are covering meal with soluble insulin, and to give basal level we are giving long-acting insulin. So this is a concept of basal bolus. We are giving covering the meals, and same time we are giving the background insulin. Again, some example. So again, this patient need a basal bolus regime. So there are some so basal bolus and sliding scale insulin. Sliding scale is a very old-fashioned one, and it has been analyzed head-to-head, and this is a rabbit T2 trial. It shows very clearly, and basal bolus gives a very smoother control, less hypoglycemia, and patient outcome was better with the basal bolus regime. So how to calculate the basal bolus is we are calculating according to patient body weight. Suppose the patient is insensitive, like elderly patient, chronic kidney disease, thin patient, or malnourished, and we can use a 0.3 into kilogram body weight as a total dose required. And moderate insulin sensitive, like type 1 diabetic mellitus, we can use 0.4 kilogram body weight. And insulin resistant, like post-surgical on steroid and obese patient with obvious features like acanthosis nigricans, we can take as a 0.5 to 1 into kilogram body weight as a total daily dose. In total daily dose, we divide into 50% as a isopen insulin and 50% as a pre-meal insulin. So this is some example how to calculate it. And then 50% we divide into 3, and that will cover the meals. In the general surgery also, it's been recommended basal bolus is better than the sliding scale. Another thing is the patient is diabetic mellitus, his sugar level is high. Is the patient ill by mouth or the midnight for following day surgery, and we are not stopping the basal insulin, but we can reduce it to the 30 to 50%. And again, we are not giving mealtime insulin, but we are checking sugar level every 6 hours. And if the sugar level is above 180, and we give correctional doses of insulin, and that while patient will ill by mouth. And this is the scenario can be applicable to the surgical wards. So this is how to calculate things, the management. Sometimes when I give basal bolus, we check the pre-meal CBS, and their pre-meal sugar level can be high. So then we have to give correction dose in addition to our already calculated basal bolus dose. And these are some algorithms to give that corrected dose. These are some examples to get the to give the corrected dose of insulin with the basal bolus private meals. Again, summary: oral antidiabetic agents are generally not recommended in the setting of infection. Continuous IV infusion can be accepted only for ICU setting, and selected surgical patients who cannot be feeding, and patient who might be in total parenteral nutrition, those patients we can give continuous IV insulin. And most of other patients, especially for medical patients and surgical patients who are taking orally, the best option is give the basal bolus insulin. This is some indication why we are not recommending oral medication, especially metformin can cause lactic acidosis, sulfonylurea have very high risk of hypoglycemia, thiazide can cause heart failure and fluid retention, so on. There can be complications with oral medication that why we are stopping. Soon they come to the ward and start on insulin. On discharge, with the patient, type 2 diabetic patient, if you are controlling with a daily dose of less than 25 units of insulin, they can be converted into the oral medication. While in the ward, this patient need to maintain the sugar level optimally more than 25 units per day, and those patients we have to continue with some insulin. So those patients, no point converting back to orals because they can't achieve the control. So one example, other scenario is patient diabetic can come with MI. Most patients diabetic, they're not critically ill, so they can eat. Therefore, we are not going to very aggressive management of sugar. Supposing they got MI, sugar level is well under control while they are on oral medication. In that scenario, we don't need to change the medication. We can continue while monitoring sugar. But if sugar level goes above 200, then we have to intervene. So basically, we are starting insulin. Now, unstable patient with hyperglycemia, like cardiac shock, those patients, we stop oral medication, we are going to a basal bolus regime insulin. And this one common scenario, regular patient comes to clinic with the fasting number 240. She's otherwise normal, asymptomatic, and patient not taking medicine for 3 days prior to come to the clinic. What is the next step in the management? This patient no features of diabetic ketoacidosis, no sepsis, otherwise well patient come to the clinic with high fasting blood sugar. Not take medicine for 3 days, but before that, she had very optimal control. And this patient are not dehydrated. And this kind of patient no need to admit to hospital. And what we have to do is, we can give the same doses of medicine and can repeat 1 week time with the fasting blood sugar. If the patient has features of dehydration, you do not put reduce, mouth is dry, blood pressure low, those patients need admission and hydration, then restart of the medication. Another scenario is a 75-year-old patient. A patient is the fasting blood 140 from the clinic. And this patient, no other complaint, no features of ketoacidosis, patient alert, not dehydrated. But this patient need admission because elderly patients are at a high risk of dehydration going to hyposmolar state. This patient need admission, need IV hydration, and after IV hydration, still sugar level is high, may need insulin, and once patient settle, can start oral medication discharge. Because elderly patient are in high risk of getting hyposmolar state. Therefore, elderly patient need admission with high sugar. Another example, one case is missing. Yes, all right. Other thing is, something slide is missing here. Suppose we get a patient with with the patient with a low IQ, we can guarantee on his with the eating or drinking enough. Those patients coming with a very high sugar level again need admission because we don't know this patient going to eat and drink enough, and with the patient going to take medicine properly. As far as patient taking enough fluid and to counteract his urine output, he's not going to hyposmolar coma. And once if the patient stop drinking fluid, only they go into hyposmolar coma. Therefore, mentally subnormal patient, psychiatric patient, patient low IQ need admission, hydration, and inpatient care. Sorry, Lakshan. So Lakshan. Oh. Oh. Mana, tapi nanti kita itu tak boleh. CVA is the patient either require another person assistance, and so this patient can be correct aggressively. And if the patient getting hypoglycemia with the 70, we have to reduce the dose half and give the insulin dose if needed. Hypoglycemia 50, we are stopping the dose, and severe hypoglycemia not give dose and need IV dextrose. Sorry. Thank you very much. I'm in the extreme emergency, so I have to leave now. Once you come to the ward, we'll see further management of diabetes. Thank you very much.
Right. Thank you, Sid, for your informative.
I'm in extreme emergency. I have to go now.
It's okay,
Thank you
sir.
very much.
Right. Yeah. So we're going to go up to the last lecture for the day by Dr. Shari Vaningaratnam. Madam tried to log in then. So I think she's logged in. On anaphylaxis. Over to you, madam.
Yeah, I can hear you, but I'm just trying to share the video. Can you see now, Roshan?
It's coming up.
Right, okay. Afternoon, and sorry for that technical delay. So today, our last topic, an approach to a patient with anaphylaxis.
Madam, it's,
Can
madam,
you all
need
hear?
to make it full screen.
Right, okay.
Went off. We'll try again. Is someone helping you there, madam? Or you are muted?
Just, yeah. Can you see my screen now?
No, madam, not yet.
Right. It's muted, it seems. Right.
I'll share it from here, madam. It's okay.
Right. Okay. Let him share. තුෂාරි W කියන එක බලන්න ෂෙයා කරලා post කරලා.
Okay, full screen, please. Madam, full screen kind of.
Are you all right now?
Madam, full screen can.
Hello, Roshan. Can you see the screen now?
Now we can see it, madam. It's not full screen. It's on normal minimize screen. You have to go to that presentation mode. Madam, icon.
Can you see the screen now?
We can see the screen. Full screen. Madam, but is full screen. Full screen. Madam.
Hello.
Not yet, madam.
No.
I'll share it from here, madam. It's okay. It's okay. I'm sharing it here. Okay, understand.
Hello.
Madam, we are sharing.
Right. Okay. I can't see the slide actually. All right. Okay. So this is the, sorry for all the technical faults. So this is the outline of my lecture. I would like to talk to you regarding what is anaphylaxis and what is anaphylactic shock and pathophysiology, how to diagnose, triggers, and the meaning of few words about biphasic reaction, refractory anaphylaxis, fatal anaphylaxis, and how do you treat. I think you all must be very tired now. Here, we'll go from very basic, and at the end, only 3 things I want you to remember. Next slide, please. Roshan, next slide. Right. Now, let's see what is anaphylaxis. Anaphylaxis is a severe, life-threatening, generalized or systemic rapid onset hypersensitivity reaction. Now, you know your allergies. If you are bitten by an ant or if you have encountered any allergy substance, you get skin changes, you get urticarias. But how it differs from anaphylaxis? Anaphylaxis is a systemic involvement of this allergy. Anaphylactic shock. All of you must be knowing regarding the shock. Shock is due to low blood pressure, your organ perfusion get compromised. Similarly, in anaphylactic shock, there's a increase in vasodilatation resulting in low blood pressure causing shock. It is a potentially life-threatening emergency and you required immediate diagnosis and management. Next slide, please, Roshan. Right. Can you all hear me?
Yes, madam, can hear.
Right, okay. Now let's see the pathophysiology. I think most of the things in anaphylaxis, you would recall your basic medical student days. Here, the major cells playing a role is mast cells and basophils. So when you encounter with this allergen, they are preformed granules inside these cells, which causes release of histamine and tryptase, and sometimes new chemicals generated and released to the blood circulation, which has effect in the skin and mucosa, the respiratory system, gastrointestinal system, cardiovascular system, and central nervous system. Here, the important fact is, if you want to diagnose anaphylaxis, usually we are not doing any blood test to diagnose, but if you really want to diagnose, here you can measure the blood tryptase level. That's a common, even the MCQ in your exams, especially in MRCPs, you diagnose with blood tryptase in acute stage within 4 hours. The next slide. Right. So how do you diagnose? There are certain definitions. So there are 3 criteria. Acute onset of an illness. Here in medicine, history is very important. If a patient comes and tells you, this has happened 2 or 3 days back, then you can't take it as anaphylaxis. This is acute onset of an illness, minutes to several hours, involving your skin with generalized hives, pruritus, and flushing, and also the mucosal tissues, swollen tongue, lips. I'm sure you must have seen this picture. But to call anaphylaxis, we need to have A, B, C, and G. A is your airway and breathing. With that, you get wheezing, bronchospasm, shortness of breath, stridor, hypoxia. C is your low blood pressure and associated symptoms of end organ dysfunction. G is something new. Sometimes without A, B, C, you can get severe GI symptom, severe crampy abdominal pain, repetitive vomiting. Sometimes you may think I'm dealing with acute food poisoning. It is possible, but with the background history of allergy, acute onset with this skin involvement, you might have to think of the anaphylaxis. Here, the important thing is diagnosis anaphylaxis or anticipating and act quickly. Next slide, please. Right. Second criteria, this is very important. Here, you don't see your skin changes or mucosal involvement, but suddenly, if you are precipitant to allergen or sometime without the precipitant history, suddenly you get hypotension and collapse or bronchospasms or swelling around your lips and throat. And important thing is, again, it's a sudden onset thing, and with progress minutes to several hours. 20% of anaphylaxis patients comes into this category. So when you become house officers, always, if you anticipate anaphylaxis, don't go with the skin and mucosal involvement only. Next slide, please. Right. Now, third criteria, again, important, reduce blood pressure after exposure to a known allergen for that patient. Again, it occurs within minutes to several hours. How do you define your low blood pressure? In adults, blood pressure less than 90 millimeters mercury or 30% drop from the person's baseline. Even in the absence of typical involvement, still you can count it as anaphylaxis. So there are three criteria laid by British Resuscitation Council. Next slide, please. So these are the pictures stating the same thing, sudden onset of illness with involvement of skin, mucous tissue, or both. Next slide, please. This is your second criteria again, the pictorial illustration. Two or more of the following that occurs suddenly after exposure to a likely allergen or other trigger for that patient. Quick onset, progress minutes to several hours. Again, ABC, skin and GI problems. Next slide. Reduce blood pressure after exposure to a known allergen for that patient. Because I'm going slowly and elaborating, this is an emergency. As intern house officers, all of you should identify and treat immediately. Next slide, please. Next slide, Roshan, please. Right, now let's go to a case history where we have encountered these two patients in the ward. This is a 41-year-old clerk admitted to ETU with sudden onset urticaria rash all over the body, including the face and shortness of breath. He has presented to the ETU after 15 minutes of his breakfast. He had similar episode 1 month back, same at this presentation following a meal. So he has urticaria, skin rash, blood pressure has crashed, now 80/50, pulse rate 130, saturation low, and he has this airway constriction by basal bronchi. So what is our diagnosis? I'm sure all the interns who is going to start their internship, listen to this lecture, will never fail in diagnosis anaphylaxis in this patient. So here, patient has got anaphylactic shock. So next slide, please. Right, this is another patient on the same casualty day we have admitted to our ward. 15-year-old schoolboy presented to the ETU with sudden onset itchy urticaria rash following an exercise. He's a known patient with childhood bronchial asthma and allergic rhinitis. So he has skin involvement, sudden onset of symptoms, but he has no involvement in A, B, C, or G. Blood pressure 106/66, pulse rate 92, and saturation 98, lungs normal. So what is your diagnosis? Here at this moment, we cannot take this as anaphylactic shock, but we need closely observe this patient to see whether he will go into shock. So at this moment, we can't take it as anaphylactic shock. Next slide, please. Right, some pictorial illustrations. You have trouble in breathing or wheezing because of upper air involvement. You have facial swelling. You have nausea, vomiting, and skin involvement with hives. Next slide, please. Right. Similar thing again and again to keep these things registered in your mind. Swelling of lips, swelling of the tongue, swelling of the throat. You always have to see and pick these clinical signs. Severe stomach pain, dizziness, difficulty of breathing, a weak and rapid pulse. Am I dealing with anaphylaxis and anaphylactic shock? Next slide, please. Right, signs and symptoms again, you can see here the urticaria in the body and the hand, you have itching and again urticarial rash, the small child periorbital swelling, and the other small child, he has angioedema with swelling lips. Next slide, please. Right. In the left-hand corner, you see the normal allergy symptom, tearing, redness, runny nose, rash. This can occur to you or me in the morning where we are very prone to allergies. So this is not anaphylaxis. This is just allergy in case allergy involving these nasomucosal allergic rhinitis. And the other pictures, again, I'm showing again and again the signs of anaphylaxis. Next picture, please. So this is one of the important pictures. Here, the anaphylaxis reaction, the histamines, tryptase, all the chemical mediator resulted in mucosal swelling. You can see swelling around lips, tongue, again pharynx, and whole upper way got swollen. So this is very important condition where you need to address the airway very quickly. If not, patient will go into respiratory arrest. Next slide, please. So my dear doctors, these signs and symptoms, there's no time for you to take books and read things. You have to think fast and then act because this is a medical emergency. You know, these days, it's very timely topic because you can hear a lot of incidents with anaphylaxis throughout our hospitals. So always think fast and act quickly. Next slide, please. Right. So anaphylaxis is a spectrum of disease. It can involve mild localized symptoms without lips and face swelling, generalized skin reactions, and ABC problems with skin symptoms ranging from mild symptoms to severe anaphylaxis. So it's a spectrum of disease of allergy ending up in severe anaphylaxis. And if it is so, the fatal anaphylaxis. Next slide, please. Next here. Now, what are the triggers and reaction times? Most common triggers are foods, insect bites, drugs. Here for us, drugs is very important. Less common causes are tick bites, exercises, cold temperatures, radio contrast agents, injection. Sometimes you cannot find any trigger substance. When you take the history of patients, you have to ask during the last 6 or 8 hours, what sort of food you have taken. Food allergy occurs 1 to 2 hours. Stings and injected medications within seconds or hours. Oral drugs can be little bit delayed compared to the IV drugs. So these are the common triggers. Next slide, please. Next slide, Roshan, please. Yeah. Again, the same thing repeating: allergic reaction, skin contact, ingestion, and inhalation. So same thing I'm repeating. Next slide, please. Right. So the immediate management positioning is very important. We'll see in the next coming few slides. And your adrenaline, oxygen, IV fluids, you need to call for help because you need a team like cardiopulmonary resuscitation. And if the patient is outside, transfer patient to hospitals. And if patient unresponsive, you need to start your CPR. Next slide, please. Right, anaphylaxis, you all can have this in the resuscitation council. We'll go one by one in details. So this is your algorithm. Everyone can download it in your internet, and you can keep it with a picture hang on your wards also. Next slide, please. Right. Now, these are simple things. Positioning of the patient. You have to keep the patient supine and you elevate the leg. I think you have already learned in your medical students' days. You elevate the leg and it increases your venous return and keep your central circulation, providing good blood supply to the vital organs. So keep horizontal, and if patient has difficulty in breathing or vomiting, you can allow them to sit. So we'll proceed with the next slide. You have your positions, but here important thing is you keep the patient supine and if possible with leg elevation. Next slide, please. Right. Correct positioning during and after an anaphylaxis event. Keep patient flat, semi-reclined positions with leg outstretched, but do not sit on a chair, feet on floor, or do not stand or walk after anaphylaxis. So it's important for you to remember these things. And again, you go back to the next slide, please. Next slide, you can, yeah. Especially the people who will work in a pediatric unit, you have to ask the mothers to keep their child horizontally. And if you suspect, or even when you are giving drugs, you shouldn't hold infants upright or over your shoulder. Next slide, please. Lie on left lateral recovery position if the patient is pregnant or vomiting. So all of you, either you work in a medical ward, surgical ward, gyn ward, or a pediatrics, anaphylaxis is very important to identify, and your first step is position the patient. Next slide, please. Right. So quick assessment: assess your airway, breathing and circulation, assess GCS. You can speak to the patient and get a brief history, examine skin, assess lips, tongue and oral pharynx, check the blood, ask your team nurses to check the blood pressure, check the saturation, pulse rate. So this is quickly done in any emergency. Next slide, please. Right. This is the most important one of the few slides in this lecture. Adrenaline is the first line treatment. So what happens in adrenaline? Adrenaline will reverse all the effects, bad effects caused by histamine and tryptase. Adrenaline reduces airway mucosal edema because histamine and tryptase increases mucosal edema, which has blocked your upper airway. So it reduces airway mucosal edema, and it causes bronchodilation, and it causes vasoconstriction, and you keep the blood pressures high, and it increases strength of cardiac contraction. It suppresses histamine and leukotrienes, and it stops these bad effects on the body, and it inhibits mast cell activation. So adrenaline is the first line treatment. So here you can see the adrenaline pictures, but in the wards, you just go and see these ward vials, very small vials come in 1 milliliters. Next slide, please. Adrenaline. So dose, you have your wards, 1 milliliter small vials, 1 in 1000 dilution. So you take this 1 milliliter into a syringe, but in an adult, you can give 0.5 milliliters. The people who weigh more than 50, you can give 0.5 milliliters. And it's an intramuscular injection. Since it's an intramuscular injection, you have to take a long needle. Otherwise, your adrenaline will end up in the skin or subcutaneous tissue. So you have to get a long needle, 1 cc syringe, get this adrenaline 1 milliliter, but you first inject only 0.5. And where is the place? It's in the upper right-hand picture. It's your mid-thigh, upper mid-thigh laterally. You inject. And you just see the response. If not, after 5 minutes time, you can repeat it again. So don't keep these things to remember later. Always remember 1 in 1000 adrenaline, 0.5 milliliter IM stat to intramuscular and outer thigh. Next slide, please. It's not available in our country, but the doctors who will be going abroad or the people who have relations can get this if you know someone has anaphylaxis. These are adrenaline auto-injectors. They are designed to administer single fixed dose of adrenaline. Can give by anyone, including people who are not medically trained. And there are different auto-injectors available depending on the adrenaline dose. So in Australia, you have EpiPen and Anapen. EpiPen for children less than 25 kilogram, and the Anapen is for children, and EpiPen is for adults who are weighing over 25 kilograms. So this, at least you should know, there's a thing called these auto-injectors, and when you inject this insulin, you don't have to remove the clothes. You can go through the cloth and jab to your thigh, avoiding the heavy seams or separate different multiple layers of clothes. Next slide, please. Right. When it comes to adrenaline, there are no absolute contraindications to adrenaline in the setting of anaphylaxis. So don't think I'm a little bit worried of adrenaline when tachycardia, whether it causes heart attack or whether it causes arrhythmias. In the background of anaphylaxis, you don't think of those. You straight away give adrenaline because it reverses all the physiological effects. So here, these charts are available. You can download it, and when you go to your wards, you can display it in your emergency trolleys. Next slide, please. Adrenaline then next moves to IV fluids. You have listened to a lecture in dengue. Dengue, what happens? Due to the different permeability in the epithelium, the fluids tends to leak out. Similarly, there are two reasons why patient get hypertension. One thing, patient has vasodilatation. Other thing, the leaking of fluids out. So you do not hesitate to give large volume IV fluids. Here, only 3 messages I need to give. You have to insert a large bore cannula, 14 or 16. Don't go for a small cannula. Put a good large cannula, and normal saline is the IV fluids that you choose. Dextrose or ringalactates can cause devastating effects. If you fail to go for the IV access, you can go to the intraosseous access. So normal saline, wide bore cannula, and you give quickly. Next slide, please. ARV management and supplemental oxygen. You need high flow oxygen. You go 15 liters per minute in either nasal prongs or rebreathable mask. If you think upper airway is involved, patient has difficulty in breathing, low saturation, always you call for the help. Either it's the emergency physician, your seniors, or anesthetist team, because in the background of laryngeal edema, intubation is going to be difficult. They have to practice difficult intubation procedures and proceed with this background. So you need expert help. Next slide, please. Next slide, please. Right. Here, when it comes to bronchodilators, you would think of your salbutamol. No, in the background of anaphylaxis, it is again, we expect your IM adrenaline would cause your bronchodilation, or if not, you can try with adrenaline nebulization. You take 5 adrenaline vials and put to the nebulizer, and you can nebulize. Adrenaline nebulization, IM adrenaline, again, is the first drugs to use. And there's a place of salbutamol nebulization if you think patient has underlying bronchial asthma and he has a contribution from this asthma part for his airway constriction. But still, it's the adrenaline you try, and it is the drug of choice even for the bronchoconstriction. Next slide, please. Right, these are very common. You might have taken your Pre-Intern cetirizine. With the background of anaphylaxis, it can relieve itching and urticaria. It cannot substitute for adrenaline. It do not relieve upper or lower airway obstruction, hypotension, or shock. No evidence for any survival benefit. If the patient can take orally, you can give loratadine, desloratadine, or fexofenadine if patient have skin rashes or urticarial rashes. You also can give famotidine. It an additive effect to relieve the skin involvement of these allergies. Next slide, please. Right. This is one of, again, the important slides. When it comes to allergy or anaphylaxis, you know, earlier, we have give this IV hydrocortisone. But in the background of anaphylaxis, IV hydrocortisone has very minimum place, and in fact, it has little evidence of benefit. It's usually given commonly, but still it's little evidence of benefit. But similarly, if the patient has a background history of asthma or patient is not repeating, you can consider, but there's no added benefit by using hydrocortisone. Next slide, please. Right. Now, whether you, I'm pretty sure whether you have heard regarding the refractory anaphylaxis. What is refractory anaphylaxis? It defined as persistence of airway, breathing, circulation features despite 2 appropriate doses of adrenaline, 2 appropriate doses of IM adrenaline. Then you will change your management to the refractory anaphylaxis protocol. But mind you, this is involved with IV adrenaline infusion, where you need to seek superior or senior opinion to initiate this or proceed. Next slide, please. So at IV adrenaline, you mix 1 milliliters of 1 in 1000 adrenaline in 100 milliliters of normal saline, and you give via infusion pump, and you monitor the patient while IV adrenaline going on. And initially with the peripheral line, ideally patient needs central line. Patients who are on IV adrenaline should be managed in HDU or ICU because they can cause pulmonary edemas, arrhythmias, tachycardia. So they might be in strict observation, and you have to assess the patient and escalate and de-escalate the drug doses. Next slide, please. Right. Just for your knowledge only, you can use selective vasoconstrictors, metariminol, vasopressin, but only this is for ICU setting. Next slide, please. Again, for your information, you can give glucagon. If patient taking beta blockers and refractory to adrenaline, can use IV glucagon bolus, dose 1 to 2 milligram IV bolus over 5 minutes, and you can repeat it. It has inotropic and chronotrophic effects that are not mediated through beta receptors. So these other vasopressors, IV adrenaline, glucagon are all used in severe anaphylaxis under experts' opinion. Next slide, please. Right. Now, as an intern, when you manage your anaphylaxis patient with 2 intramuscular doses and you are keeping the patient in the ward, all patients should be observed until signs of anaphylaxis fully resolved. And patient need to manage in HDU, or you might have sent the patient to intensive care unit. If patient become less symptomatic or hemodynamic parameters improve, can decide on further action plan. So you don't put the patient to the cornermost bed in the ward. You keep the patient in the front, and you regularly go and observe the patient and monitor the patient. Next slide, please. Next slide, please. Right. What do you mean by fatal anaphylaxis? It's a serious anaphylaxis reaction, rapid in onset, results in death. So you don't have time. They just fall with death. So these are the incidents which happened recently. They are our fatal anaphylaxis. Sometimes 100%, you cannot avoid anaphylaxis. Sometimes it can happen, but what you should know regarding it, and anyway, you should know to manage your anaphylaxis with confidence. So beta-lactam antibodies, penicillin, cephalosporin is quite common. So you are the first encounter history taken person in the ward. So always you need to ask from the drug history and write it in red in your bed ticket and inform the nurse who is in charge for that cubicle or person also tells that this patient has anaphylaxis to penicillin. So be careful. So you have known just without writing just in blue and among your notes, you have to pay a special attention because the deaths have happened due to these mistakes, and those are preventable deaths. So radio contrast agents, anesthetic drugs are common, and most of the time it's iatrogenic agents. So within 5 minutes, they just collapse. And again, stinging insects, venom-induced or food-induced anaphylaxis can cause fatal anaphylaxis. So drug history, allergy history, you need to pay special attention. Next slide, please. Right. What is biphasic reaction? Here, you get this antigen exposure and patient develop this anaphylactic symptoms and you manage it. Then patient become well and patient parameters become improved. But without exposure to a second allergy, a patient get this chain of reactions without exposing to the allergen. So that is very important for you to keep this patient in the ward and monitor them rather than just sending in 2 or 3 hours. So There's an entity called biphasic reactions where you can get the same chain of anaphylaxis without an exposure. So it's very important to know this concept. Next slide, please. Right. Now, who are the people who are prone to get biphasic reactions? Patients have more severe initial presentation of anaphylaxis, or if initial reaction requiring more than 1 dose of adrenaline, or delay in adrenaline administration, more than 60 minutes from onset of symptoms, or previous biphasic reactions, there's a risk of these biphasic reactions. Again, in the history, with this anticipating anaphylaxis patients, you need to get these informations if they have a previous episodes of similar anaphylaxis. So you keep this patient for 48 to 72 hours, make patient is very stable before discharging. Next slide, please. Next slide, please. Right. Now, few more slides only. Discharge care, all patients who have experienced anaphylaxis should be sent home with the following: anaphylaxis emergency action plan. If you are in another country, or if possible, the epinephrine auto-injectors, printed information about anaphylaxis and its treatment, documented advice to follow up, if possible, with the allergist, or if referral, if available. Next slide, please. So, what is our responsibility? We have to be very thankful to the College of Internal Medicine and the Ministry for arranging this series of lectures. We should educate our teams, doctors, nurses, minor staff regarding anaphylaxis. And we have to observe and supervise all your emergency trolleys, whether they are equipped with drugs and the other syringes and the equipments to manage acute anaphylaxis. We need to display acute emergency drug doses, IV infusion tables, anaphylaxis management flow charts in our wards. We should educate the patients regarding anaphylaxis, and when needed, get the informed written consent. Always document the allergy history, anaphylaxis in the BHT. If possible, when you discharge the patient, refer to the immunologist, but this service is very scarce in our country. Patient education regarding avoidance or identification of allergens, very important. Next slide, please. So what would be the take-home message? Look out for anaphylaxis and act fast. You need to call for help. Position the patient correctly. Adrenaline is life-saving, 1 in 1,000, 0.5 milliliters IM stat, the adult dose. Fluid resuscitation with normal saline. Oxygen, proper monitoring, patient education, and safe discharge plan. Refer to the immunologist or allergy testing if available. Now, I think you must be really tired of these days. You are now going to start the very important period of your life. So if you forget everything, remember your adrenaline, normal saline, and oxygen, only those 3 words. Right, next slide, please. So this is my referral. Next slide, please. So all the very best for a very successful, next slide, please. Right, all the best for a successful internship. So be strong as you fight your way to success. The difficulty you face is nothing compared to the joy of success. You'll be blessed with all your good work. So I hope you will be very good doctors. And let me thank again the College of Internal Medicine and the Ministry of Health, the President, Dr. Kumudini Jayasinghe, and the coordinator in the Ministry of Health, Dr. Roshan Fernando, for arranging this. and all of you, in spite of the time, listening very patiently. Thank you very much. If you have any questions, if you put in the chat box, I can answer.
Yes, if you all have any questions regarding anaphylaxis, please take this time to ask question from Madam. Either you can use the chat box or unmute and ask. Right. If there are no questions, so we will wind up today's program. So I sincerely thank Dr. Tushari Maniga Ratnam, Madam, for delivering a wonderful lecture, a profound lecture on anaphylaxis, which is a very widely spoken topic these days. So thank you, Madam, for sharing this knowledge with the newly interns. So thank you once again.
Thank you very much.
So we conclude today's program. So we will share a link to evaluate today's yesterday's and today's sessions. So that will be taken up as the attendance. We will share it now. Right, Monday join by 8:45 for psychiatric sessions. Okay, thank you.
So where's the link?
Sorry?
Link, sir. Attendance.